Sheffield, James Sanderson, who is Chief Executive at Sue Ryder, and Dr. Sarah Cox, who is the President of the Association for Palliative Medicine. For this session, we have until 3:15 p.m. And could witnesses please introduce themselves for the record, please? Starting on the left.
I'm Dr. Rachel Clark. I'm a hospital palliative care doctor with a decade practicing in a whole range of settings: the community, hospices, small district general hospitals and a large teaching hospital. I'm also a former journalist and current author who has written 4 best-selling books for the public about medicine in the UK. I campaign very actively for greater awareness amongst the public around the topic of death and dying. And I have extensive experience teaching communication skills to medical students, junior doctors, nurses and other members of the MDT. My personal view on assisted dying is I'm not opposed in principle, but I have significant concerns around the issues of consent and capacity.
Good afternoon. My name is James Sanderson. I'm the Chief Executive of Sue Ryder, a leading palliative and end-of-life care organisation who also support people living with grief and bereavement. I've recently joined Sue Ryder. I've been there for 6 months. I was previously in NHS England as Director of Community Health Services, Personalised Care and Palliative and End-of-Life Care. I'm the former Chief Executive of the Independent Living Fund. Sue Ryder as an organisation have adopted a neutral position in regard to the assisted dying bill, and I'm here today to provide information regarding the provision of palliative and end-of-life care and some of our concerns in relation to how the system is currently operating across the country. Thank you.
I'm Sarah Cox. I'm a consultant in palliative medicine. I've been in palliative care for over 30 years. I'm also the president of the Association for Palliative Medicine of Great Britain and Ireland. It's a member organisation with over 1,400 members. There are naturally different views amongst our membership, but in polls over the last 10 years, the results show that about 80% of our members are opposed to legalisation of assisted dying, about 5% in favour. And the reason for the opposition are many, but some of them include the inadequate current provision of palliative care, which doesn't offer patients a choice, concerns about how the safeguards would be enacted in this bill, and concerns about the impact of assisted dying on palliative care resources, funding, and on the workforce.
Thank you. Thank you very much for inviting me here today. My name is Sam Ahmadzai. I'm a retired professor emeritus of palliative medicine from the University of Sheffield. I have, not boasting, Sarah, but 39 years of experience in the specialty. I was one of the people involved in setting up the new specialty of palliative medicine back in the 1980s. My experience is of working in a hospice for 9 years and then 20 years as a consultant and professor at the University of Sheffield. I'm a clinical academic, so I take very much an evidence-based view of healthcare, and palliative care is just another kind of healthcare. For instance, I chaired the NICE guidance on the last days of life. I was clinical advisor to the NICE guidance NG 142 on service delivery in the last year of life as well. So I come from that background. My experience around has been around the world, visiting academically, lecturing, working. I was visiting Spinoza professor at the University of Amsterdam for 10 years, where I lectured people who were actually delivering euthanasia in Amsterdam about what they could do in terms of palliative medicine as well. So that's where I'm coming from. I'm a supporter of the changing the law, and I commend this bill. I think it's one of the safest I've seen in the world.
Thank you. If members could indicate if they wish to ask a question, and we'll take names down, and then if you indicate who you want to ask the question to, if that's okay. Nice shot.
Thank you. Thank you, Chair. Thank you very much for those introductions. Mr. Sanderson, I've got a few questions for each one of the panel. In the first instance, Mr. Sanderson, do you think palliative care in this country is fit for purpose?
Thank you very much for the question. So I think there are clearly gaps in the provision of palliative care. However, starting with a positive, I think the provision of palliative care that we have in this country is exceptional. And I think we are actually leaders in many ways across the world in the way in which we support people who are facing those challenges in their lives. However, our findings in relation to palliative care show that whilst about 90% of the population could benefit from palliative care, only 50% of people currently able to access it. And one of our concerns is that the provision of palliative care across the country is quite patchy at the moment. I don't think there's been a thorough assessment of the level of palliative care in place. And not just the provision of palliative care specifically, but how other services, such as district nursing services, for example, interact with palliative care. Because in some areas, the provision of district nursing services for general care and support for people who may be at their end of life is very strong, and in other areas it is not so strong. So at Sue Ryder, one of the things that we are really concerned about, and our survey showed us that 77% of people said that they were concerned about the lack of availability of palliative care, and enabling more people to consider an assisted death than otherwise would. And actually that concern went up to 84% for those who were in favour of assisted dying. So I think that's one of the things that we really need to look at, is the provision of palliative care and the specifics in the Act that make reference to the fact that people should be offered what is available to them. I think we need to have a much clearer definition of what available actually means.
Thank you very much. Dr. Amazai, I understand from your evidence you've submitted, you've said you studied the reports from and spoken with medical and nursing clinicians from the US and the Australian jurisdictions, and I'm satisfied that external coercion has never been reported or led to a prosecution. The state of Oregon carried out a survey of people who died under its assisted dying scheme. In 2023, the state of Oregon itself said in its report, assisted dying, that 43% of those who died said they did so because they felt they were, and I quote directly from the term used in the survey, a burden on family, friends and caregivers. Is that something you're prepared to see happen in the UK?
Thank you. If I can start with saying that it's absolutely come to the core of being British, that we're always saying sorry, aren't we? We apologise for everything. Everything we do, treading on toes, think we might do, we're always worried about being an imposition. And all my professional life, I've come across patients and families in which there clearly is that feeling going on, usually with an older person or even a younger person who's drawing a lot on the emotional, physical resources of the family. That it's natural that we feel a burden. It's impossible to take that out of the human nature. The issue is, does that feeling that one is or might become a burden something that could influence a decision as major as looking for assisted dying? In that respect, I look to all those jurisdictions where they have been offering assisted dying in different ways, and I have never seen a single case ever taken to the police or prosecuted, and evidence I've heard from other jurisdictions show that yes, it's possible, because we all go through life feeling that we're a burden on someone, but it does not influence people in this particular decision. If anything, I'm told that in other jurisdictions, families are saying, no, don't do it. They're exerting, negative coercion, don't do it coercion. But people are saying, no, it's my life, I've made my mind up. They have mental capacity, and we respect that.
Thank you.
Thank you. Sean Woodcock.
Thank you. We had lots of, now again, coercion is one of the main issues that people who are concerned about the bill raise as why they are in opposition to it, that would include myself. We had many distinguished witnesses this morning, and the view was that, to quote, coercion is rare in healthcare generally, but also it's rare, and that staff are so well trained, have safeguarding training, etc., have such a level of experience that it was almost given across that we didn't really need to worry about it. I would put to the panel your views on that. Is it really something that those of us who are concerned about coercion, is it really something that we should not be so concerned about? Yeah, that'd be great.
Well, I would, and this is based on my clinical experience, I would strongly push back on that in the strongest terms. I'm the kind of doctor who believes there is nothing to be gained by sugarcoating reality. We have to be absolutely honest with patients, with the public, about shortcomings, failings, areas where my profession, the rest of the NHS are getting things wrong. And it is my clinical experience that not only are the majority of doctors not necessarily trained in spotting coercion explicitly, they're often not trained explicitly in having so-called advanced care planning conversations with patients around the topic of death and dying and how a patient would like the end of their life to proceed. It is almost impossible for me to overstate how much avoidable suffering occurs right now in the NHS, not because of lack of resources for palliative care, although that's an enormous problem, but because of lack of confidence and skill and expertise amongst the medical profession writ large with these very difficult conversations. We're all familiar with the idea of death and dying being a taboo in society. People are scared of it, they hesitate about bringing it up with their friends, family. Well, in my experience, medical students and doctors, many of them also suffer from that anxiety. They are scared, they find it a taboo subject. And what that means is sometimes coercion occurs because literally the doctor, the consultant responsible for this patient's care, won't even bring up the fact that they think the patient is dying because it's an uncomfortable conversation. Conversely, I have worked with senior hospital consultants in the NHS who have deliberately prevented our team from accessing their patients because they believe the hospital palliative care team wants to kill the patients. And if I go and see the patient, I will give them a lethal dose of drugs. So these are the kinds of extraordinary misunderstandings and failures to prioritise patient autonomy that are happening now. And that's even before we get started on conversations around whether or not someone would like to consider assisted dying. So it's a huge problem.
Thank you.
Thank you. My question is for Dr. Ahmedzai. The Select Committee report on assisted dying received evidence that there were not any indications of palliative and end-of-life care deteriorating in quality or provision following the introduction of assisted dying. Indeed, that introduction has been linked with an improvement in palliative care in several jurisdictions. So, two questions, if I may. What more could the bill do to strengthen the available choice at the end of life and the regulation of these choices as set out in the codes of practice? If you don't mind answering that first, and then I'll come back to my second question.
Thanks very much. Yes, I visited many of the jurisdictions around the world, from Oregon, where I met the original judge who brought in the law, and the doctors, the nurses, and patients who were having it. And it was clear to me that if patients had not, for instance, accessed palliative care, they were pointed towards palliative care. Obviously, you can't force anybody to go and have palliative care, but they're certainly informed about it. In the Netherlands, what I would commend is a system called SEND doctors, support and consultation in euthanasia. Forget that last word. But these are trained doctors who are working for the equivalent of the BMA, I believe, who are going and actually supporting doctors, as Dr. Clark has referred, who are not familiar with things. they often come from a background of palliative care, pain medicine, so they're making options available that, for instance, other doctors in the process have not brought up. In Australia, again, there is this clear evidence that palliative care is becoming more available. The European Association of Palliative Care produced a report more than 10 years ago, and they examined all the countries in Europe at that time and found that there was evidence that palliative care was improving in scope and availability alongside the forms of assisted dying that were happening there. So I am reassured that actually bringing in some form of assisted dying, particularly the form that's proposed here, would be a boost to palliative care, because one of the things I would like to see is that anybody that's involved in the process is constantly asking the patient, what about palliative care? You know, have you actually accessed it? Right now, if they haven't raised their hand and asked for assisted dying, no one has that conversation with them. They are in a vacuum, in a bubble, not receiving palliative care, whereas this would actually make it possibly more available.
Thank you. I've got 2 follow-up questions on that basis, very briefly.
We've got till a quarter past, to do this. So I'm going to be as lenient as I can, so to speak, in terms of questioning, but just bear in mind that and also the panel. I don't want to squash any discussion, but just bear that in mind. We've got till a 3:15 to take evidence. Okay,
thank you. On the basis of your 39 years of experience then and the select committee evidence I mentioned earlier, do you acknowledge that improvements on both assisted dying and palliative care can run in parallel and do not need to be mutually exclusive?
In the interest of brevity, yes.
Thank you. And then just to follow up, and it's an important one because you talked about the role of medical practitioners discussing this issue, which is, of course, in clause 4.2 of the bill currently. Your own evidence, paragraph 4.2, was very helpful in discussing this and makes it clear that it's entirely consistent with current medical practice and with compassionate care to raise assisted dying. And that raising that topic does not have adverse effects. How could Clause 4 be strengthened to make sure patients are presented with the range of treatment options at the end of life and relay any concerns others have raised about suggestibility where this is mentioned in isolation?
Thank you. Complicated question. I mean, the first point is that right now, as Dr. Clark has pointed out, it's scary to patients to be told that they may actually be receiving palliative care. Many patients, when it's been mentioned, say by an oncologist, oh, I don't want that, don't let them come anywhere near me or anywhere near my relatives. So it's not unusual that people may actually have an adverse reaction just to hearing about a service, but here the difference is that the person's actually asked for it. I personally believe that it would be advantageous if there was formal training, as Dr. Clark has mentioned, specifically to have the kind of conversations that we now talk about, you know, psychological issues, suicidal tendencies. I mean, it used to be thought that if you mention suicide to somebody, it's going to give them the idea. Of course it doesn't. It saves them because they say, yeah, I was having those thoughts. So bringing up assisted dying is never going to be harmful to the person, even if they hadn't thought of it. They will just say, well, it's not for me.
That's very helpful, thank you.
Thank you. Rebecca Paul.
Thank you, Chair. My question is to Dr. Sarah Cox. Can I ask what you think the impact of the introduction of assisted dying would be on palliative care?
Yes, thank you. So Professor Nicola has talked about the evidence which was written up to 10 years ago. There's actually some more recent evidence looking at the last 10 years where countries in Europe and in America, states in America, have been assessed in terms of the development of palliative care services. And what that more recent evidence shows is that although palliative care services have improved in those countries where assisted dying has been implemented, they have improved three times better in countries where assisted dying has not been implemented. So the evidence from that study shows that actually the implementation of assisted dying is impeding the development of palliative care services. I think the other thing that we're really concerned about is the impact on funding. So if it's unclear how this is going to be funded, it looks as if it's going to be within healthcare, and if it's within healthcare, then inevitably there will be competition with other aspects of healthcare, including palliative care, for those limited resources. There are finite numbers of doctors, of nurses, of side rooms in hospitals. If this is funded with palliative care and assisted dying being the same pot, then I think there will be a massive detrimental effect on palliative care, because again, we will be in competition for a limited resource. I think the other thing that concerns me is about our palliative care workforce. We know the palliative care workforce is already in crisis. Our members told the Royal College of Physicians in 2023 that 83% of them had staffing gaps, and more than 50% of them were unable to take their leave because of those staffing gaps. 43% of them said that if assisted dying was implemented within their organisation, they would have to leave. So this has a massive impact on how palliative care, both in terms of the potential for palliative care to develop, in terms of funding, and in terms of our workforce, who are really concerned about this.
Thank you. And in terms of the data that shows that palliative care hasn't improved as quickly in the locations that offer assisted dying, can you offer us any further insights onto why that may be, and what should we be thinking about as a committee in terms of the bill in order to safeguard against that happening? Because I think we all agree here that we do not want to see palliative care decline.
So I think the first thing to say is palliative care is inadequate currently, and not only do we need to not see it decline, we need to massively improve palliative care in order that this bill is actually offering patients a real choice. We know that effective palliative care can change somebody's point of view from having a terminal illness and wanting to die to having a terminal illness and wanting to live. And we also know that 25% of the people that die in this country do not have the palliative care they need. That's more than 100,000 people a year. Now, if we're denying them the palliative care they need, which might make their lives better and reduce their suffering and change their perspective about whether they would want assisted dying or not, for me, that's the priority in terms of how we reduce suffering in this group. Insights of how we prevent this happening, I don't know. I think what I've said about not having the funding together with palliative care is really important, because I think assisted dying and palliative care need to be separated in terms of how they're delivered and the funding.
Thank you so much.
Sarah Green.
Thank you, Chair. Clark, if I may. Can I ask, what are the existing statutory guidelines around end-of-life practice, and how are those decisions logged, recorded and monitored?
So the fundamental principle is always that the default is the patient has capacity, unless it's very clearly the case otherwise, that there is evidence they do not. So we presume patients have capacity. We always, as doctors, are obliged to ensure that when deciding between different treatments, patients have informed consent. So that means we need to lay out the whole array of treatment options, the risks and benefits of them all, to empower an individual patient into making decisions for themselves. And regarding the issue that's been alluded to of whether or not doctors should in fact be prohibited from raising the issue of assisted dying, it's my belief that that would actually fundamentally alter the doctor-patient relationship, because if consent is not informed, and it isn't informed if we're not laying out all the different options to a patient, then we are denying patients the opportunity to make decisions for themselves. We currently are able, a patient is always able to refuse every treatment every life-prolonging treatment in particular that they choose to, provided they have capacity. We as a doctor may think that a decision is unwise, and that's irrelevant because those days of bad old paternalistic medicine are gone. The patient makes the choice. So if a patient says, I don't want chemotherapy, I don't want to eat, I don't want anything at all, no treatment, we respect that unless they lack capacity. The elephant in the room with all of this is the capacity assessments. And anybody, I would suggest, who pretends that those assessments are easy and routinely done well in the NHS has not got enough experience of observing that happening. I teach capacity assessments to doctors, medical students. It is often the case that they are very poorly conducted. The doctor doesn't understand the criteria for assessing capacity, and that's even if it happens at all. So sometimes a paternalistic doctor will decide that a patient is dying and we should stop their antibiotics because they're clearly now at the end of their life. They have a chat with the family who say, yes, we agree, and nobody talks to 82-year-old Mrs. Smith and asks her what she feels about it, because they assume she doesn't have capacity because she's old, for example. I see that regularly, and sometimes a palliative care team will intervene in those situations because the professional and legal framework that is meant to guide this practice is just not happening. So it's a very, very fraught and tricky area, and if there was one thing that I would say to the committee regarding making this bill as robust and strong and safe as possible, it's please to consider seriously the matter of education and training from day one of medical school onwards. Death is at the periphery of a medical school curriculum. Death and dying is not taught. You might get a week of palliative care in 5 years, and that has knock-on effects all the way through at every level of seniority in the medical workforce.
I just have a follow-up question, if I may. It's around the bill introduces a monitoring and review process, including an annual report by the Chief Medical Officer, and I just wondered if you had any reflections on whether that needs strengthening.
Yes, I think in the spirit of transparency and making this as safe as possible, it needs to be significantly strengthened, and I would suggest there need to be more safeguards in place. For example, if anyone in a hospital, whether it's staff or patient or family member, have concerns around a particular case, then there should be mechanisms for those to be raised in a proactive way, just as we have guardians of safe working and freedom to speak up guardians in hospitals. At the moment, those opportunities to assess and appraise the safety in real time once a bill is in place, I just don't think they're robust enough at all, and the more we can have of that, the more that will allay people's fears, I'd suggest.
Thank you, Chair.
Daniel Francis.
Thanks, Chair. My question is to Dr. Ahmedzai. So in the paper you produced, you've talked about specific recommendations regarding training experience of the doctors involved in the process. You've suggested 5 years, for instance, and some other experience. So have you got examples elsewhere in the world where such a thing's been implemented? And do you believe in the United Kingdom we've got enough trained doctors who've got that level of experience and would therefore be partaking in this part of the process?
Thank you. You put me on the hop there because I can't quote you the actual level of training that doctors have received elsewhere, except that examples, for instance, in Netherlands, where there are additional doctors who are, through their medical association, trained in that particularly assisted dying. I can't tell you how many years in other countries. I just felt it was self-evident that you would want doctors who are experienced, 3 years, 5 years, whatever, post-qualification, who actually have seen real life. And it's up to the medical associations to stipulate how much. But I wouldn't like the idea that a doctor, immediately having got their certificate of training, is going off making these kinds of decisions. I think that that's why I suggested that ballpark figure.
Sorry, thanks, Chair. But just to clarify, there's nowhere else in the UK as well where we have that. I'm just trying to understand, it's a piece of work we'd need to go and do about are there enough doctors with that level of experience if we were to take on that kind of recommendation. But there's nowhere else in the UK in the medical profession where we insist on that level of experience either.
Probably not, but this is a very, very special situation, and it may be that once it's become embedded in the health service, that maybe that stipulation could move back. I think I'm so glad that Dr. Clark keeps coming back to training. One of the things that I think is absolutely needed if this went forward would be to take the topic of assisted dying out of being an optional thing that people might sign up for a course to become mandatory training. I mean, in the NHS we do mandatory training for all sorts of things: washing hands, lifting, basic life support. There should be basic dying support mandatory training as well. Why isn't that there? So this would then become part of training doctors up to become good at those conversations that Dr. Clark's obviously involved in teaching, but also in keeping up to date with how the law is changing too. So I think training, and I would look to the Royal Colleges, the GMC, to actually be leading on those aspects.
Thank you. Thanks, Chair.
Thank you, and thank you for giving up your time. Very high level of palliative care expertise and experience. I'm actually a practicing GP, and GPs and district nurses do a lot of palliative care with a lot of advice from you people. But what I've also noticed is that even if you have absolutely best quality palliative care, some people still would have talked to me about assisted death or shortening their death. That's what they've talked about. So would you? I'd just like to hear what your comments are about whether this is more about autonomy than symptom control.
Well, I absolutely agree that in a small number of cases, palliative care at the highest level cannot eradicate all suffering and cannot prevent a person from wishing to end their life and have assistance in ending their life. That's absolutely the case. Although I would say it happens surprisingly uncommonly in my experience, but it does happen. I think autonomy is the crux of the issue for me, because autonomy is predicated on having meaningful choices. Can you actually choose option A or option B? If option B is high quality, not just palliative care, but medical care in general, district nursing care, social care, if that is not available to you, you are potentially being pushed towards choosing, in inverted commas, option B, the route of assisted dying, not freely and not autonomously, but because actually option B has been denied to you by the real world failures, which we all know about. We're all familiar with the latest winter crisis where patients have been dying on trolleys and corridors, etc. The real world conditions that are preventing the actual option of a death in which dignity and comfort and even moments of joy can be maintained right up until the end of life, because that patient is getting the high quality palliative NHS and social care they need. I think that's the crux of the issue, because if you do not have that as a real option for patients, then we can say that they are choosing autonomously assisted dying, but actually society is coercing them into that so-called choice because it is not funding the care that makes them feel as though life is worth living. And that's why I think many of my colleagues are so concerned about legal change now. It's not because of an opposition to assisted dying in principle, it's because the actual real world conditions of the NHS today are such that people's suffering means occasionally they will beg me to end their life. And I know that that begging is coming not from, for example, the cancer per se, but because they've been at home not getting any adequate pain relief. And once you start to provide proper palliative care, very often that changes.
Move to Danny Kruger, please.
I'll just ask one question, if I may, to you, Dr. Cox. Dr. Clark said that the capacity assessment was poorly conducted. Do you think that the threshold is appropriate using the Mental Capacity Act? Are you satisfied, assuming that we could conduct these assessments adequately, do you think the threshold is safe?
I and my colleagues have concerns about the safeguards in the bill, not just the capacity assessment, but also we acknowledge that prognosis is incredibly difficult to assess accurately. Coercion, I would say, you can't always identify coercion. You can identify it when it's very obvious and extreme, but when it's very subtle, we cannot always identify coercion. And after the event, there is nobody to tell us about coercion, so it's very difficult to monitor. I think that the other thing that concerns me is that we are putting all of these assessments on the shoulders of 2 doctors individually, followed up by a High Court judge, when in any other clinical practice, when we're making very serious decisions, we know that shared decisions are much better quality and much more robust and much safer. And in clinical practice, we make all of these decisions in multi-professional teams. So I would never make these decisions independently of my team, because the perspective they bring can help me to understand things that I'm not seeing. And so I think that's the thing that I think I'm really concerned about, is how is it possible for these doctors, even with training, to have a good understanding of all illnesses in order that they can identify prognosis, neurological, cancer, every other. How is it possible for them to really understand capacity when capacity is not an absolute? It does change. It is very complex to assess. How is it possible for them to see all cases of coercion, which can be invisible? And in addition to that, are they going to be looking out for opportunities to refer to palliative care when they see somebody who has suffering that could be addressed and may change their mind? Are they looking out for untreated depression? We know that treatment of depression, again, can result in people changing their mind about wanting to die. It's a lot to ask these individual doctors to do, and that really concerns me.
Thank you. Kit Malthouse.
Thanks, Chair. Yeah, I just want to pursue that point a little, if I may, with Dr. Cox. I mean, my understanding is that your profession is already taking these decisions or supporting patients to take these decisions. So, for example, the withdrawal of ventilation for an M&D patient towards the end, or if I would decide to decline treatment, or food and water to end my life as quickly as I can. Presumably in those situations you have guidelines already or training about assessing coercion and capacity in those circumstances. And I think in some you're legally obliged, I mean, for example, advanced directives, legally obliged to comply with the patient's wishes. Are those guidelines, do you think, broadly, and those safeguards translatable across into what, I mean, from my point of view, is another choice that a patient may make to end their life?
So I think there's 2 differences that I would identify. I think the examples you give are of somebody that may be naturally dying and is being kept alive. So the difference is you're withdrawing a treatment, you're not intentionally killing them. This is the difference of assisted dying. So that's the first difference. And the second difference I would say is you're absolutely right, we do make those decisions with patients, if they wish, with their families, but in a multi-professional team. Mm-hmm. So I almost never would make those decisions as an individual doctor without the support of my colleagues, for several reasons. One, which I've said already, about the fact that it makes so much better decisions. They are safer, they are more robust. And the second is the moral distress that's associated with these decisions is much less if you share them. Mm-hmm. And that's also a worry for me, is what happens to the moral distress of these 2 doctors, the coordinating and the other assessing doctor. They're carrying a lot of moral distress, aren't they? And my understanding, it's going to be a very small percentage of all doctors that are going to want to engage with this. Maybe 1 or 2% of all doctors are going to want to be in those assessing positions. And they're carrying a lot of that distress because they're going to be doing a lot of assessing, aren't they?
Understood. Okay. The other question I guess I had for all of you, but particularly also Dr. Clark, was you've mentioned autonomy a number of times, and obviously what the bill is trying to do is to pass autonomy to the individual at a particular moment at the end of their life. And it feels to me that the picture painted is at the moment is a largely unregulated one. Right? I think you said, Dr. Clark, that there are no regulations or kind of guidelines about what is going on, and as my colleague Sarah Green said, there's no kind of monitoring or measuring of what's going on. So in general terms, given that patient autonomy is at the centre of this, would you welcome a set of rules that is understandable by patients and doctors, rather than what we have at the moment, which is a sort of casual negotiate, well, not casual, that's not the right word, but an ad hoc negotiation at the time, depending upon what the patient wants to do?
Well, I think that's not quite right, and certainly not what I intended to convey. That there are rules, there are very clear legal and professional rules and guidance and protocols around how to have all of these conversations. However, in practice, the quality of the conversations is very contingent on the confidence, expertise, training and background of the individual clinician having the conversations, and there can be, I think, a great deal of inter-doctor variability in how those conversations are conducted. So in terms of addressing that, I would suggest that in an assisted dying scenario, the crucial thing there is to make the guidance and the training as robust as it possibly can be to reduce the inter-practitioner variability.
Very good. Sorry, I mean, sorry, I'm just conscious of time. We've heard this morning how vital training is, and I think that's broadly from a number of voices that's accepted. And then I just wanted to question you about this issue of the choice that people face. And I understand the point you're making about the variable state of palliative care versus the choice that someone face, but that's obviously a kind of macro standing up. Obviously, day by day, patients are facing a choice about what's ahead of them in the next few months. I wouldn't want to put words in your mouth, but I presume you're not saying that for the good of the whole you should go through this awful death that you don't really want to go to while we wait for palliative care to catch up.
Of course not.
Right.
And autonomy...
Excuse me.
Sorry.
Order. We've got half an hour left. We've had 9 people asking questions. We've got 8 people left to ask questions. If we want to get through to ask the questions by 3:15, people will really have to have a little bit of self-discipline in relation to asking questions. And again, to the panel, forgive me, we just need answers as reasonably as possible given the circumstances. If you wish to answer that one, the last point, feel free.
Yes, so very quickly, of course, we want as much autonomy for as many patients as possible. The issue is around safeguards. So if, for instance, you say to a vulnerable patient who's just been told they have a diagnosis of terminal cancer, have you thought about assisted dying? I would suggest that stating it broadly like that is a form of pressure, and potentially you are unintentionally coercing that patient, because the very act of raising assisted dying in that way will make that vulnerable patient think, God, is this doctor telling me that my life is not worth living anymore? So autonomy is much more subtle and complicated than we assume from outside.
Thank you. Julie Campbell.
Thank you, Chair. My question, I've got one for James Sanderson, one for Dr. Clark. They're quite similar, but I'm referring to things that you said or quotes that you've made. So, James, you said, sadly, only half of the people who need palliative care receive it. My question to you is, in your opinion, who are the people who do receive palliative care and those who do not? And then my question to Dr. Clark is very similar. You've said, or quote, the population is carved up into 2 groups, those who deserve to live and those who are expendable. Could you expand on that quote and also expand on the two groups you referred to and the impact that it has on their treatment and care?
Thank you. I think you draw a really important point around not just the provision in totality of palliative care across the country, but also the inequity of access. And we do find, unfortunately, that the diversity of people that are accessing care in hospices across the country is less diverse than those that are dying in hospital. 43% of people currently die in hospital. And one of the things that I think we really need to do is move to a new ecosystem of palliative care that looks at supporting people in different settings. We do need specialist provision in hospices to support people with significant needs, but increasingly hospices are reaching out beyond their walls into the community. 80% of the work that Sue Ryder does is in people's own homes, and people tell us they want to die at home. So supporting people in their own homes enables us to access more diverse communities, enables us to get to people in their own setting. But increasingly, one of the things that we feel is necessary is provision of support inside hospital, and our alongside wards would bring support to that 43% of people who are currently dying in hospital to ensure that there is equality of access at all places, both in inpatient settings and in the community, because I think you draw a really important point that we've got to look at the totality of provision and ensuring that when somebody is offered palliative care and the Act talks about that provision being available, that there is universal access, and that is both in terms of the type of palliative care that's available, but the access to everybody in society as well.
Thank you.
And my comment refers to the fact that there is an immense gulf between the theory of the NHS being a cradle-to-grave service, a service that cares for us at the end of life as it does at the start, and the reality. And the reality that I see every day at work in my hospital is patients coming into the emergency department from the community in sometimes utter, abject misery, agony, lack of dignity. They have been forgotten completely. They're not getting health care, they're not getting social care, no one cares about them. Even in the hospital, patients sometimes who have a terminal diagnosis are cast out into the corners of the hospital. There are hospitals, and mine is one of them currently, where we don't even have a 24/7 palliative care service face-to-face. So for every night in the hospital and every weekend, Friday to Monday, you cannot see a palliative care nurse or doctor in my hospital, despite the fact that for a number of years that's an NHS standard. That's an absolute disgrace, and it shows how little people who are dying are truly cared for in a civilised society. And this doesn't necessarily have anything to do with assisted dying, except if we do not address that simultaneously, then some of those people will choose, in inverted commas, to end their life because we as a society don't care about them enough to give them the care that might make life worth living, and that's a travesty, surely, for Britain.
Thank you. Thank you.
Thank you very much, Chair. Can I turn to the subject of registration of deaths, which is dealt with at clause 29 of the bill? And it's a question to Dr. Clark and Dr. Cox, whether they feel that the provisions set out there are sufficient, and if not, what further bolstering of those would provide the oversight that the processes and procedures are being followed correctly.
So my understanding of the plan is that in the bill, forgive me, I'm sketchy on this, but that the aim would be the registration would be as a natural death. It would not be referred to the coroner, and assisted dying would appear on the death certificate. I'm also a medical examiner, and my concern around this is, as a medical examiner, I'm obliged to scrutinise all deaths by law to ensure that a referral to the coroner is not required, and to identify any learning. And what concerns me in that role is there enough recording that's happening around decision making and the process that I can actually do my job properly with my medical examiner hat on? Do I actually know what happened? Because I don't see in the bill anything written down about the records that are being kept, what happened when the patient took the substance, what happened afterwards, and any actions that were taken in the meantime. I think this is not so much something that, with my palliative care consultant hat on, is something that I've thought about a lot, but as a medical examiner, that does concern me.
I'd ask the same question of Dr. Clark, if I may.
For the sake of time, I don't have anything to add. I completely agree with that.
Great.
Thank you, Chair. Dr. Cox, just to follow up on one of the things you said earlier, if that's okay, and forgive me if I've misunderstood, just be really clear. I think one of the things you said earlier was that in the countries where they didn't have assisted dying, the state of palliative care had improved more quickly than the countries that did. Is that a fair representation of what you said?
European countries and American states.
Sure. I mean, in terms of the UK, would you say, and you've painted, I think, the whole panel, and we've heard previously a pretty bleak picture of the state of palliative care in the UK. Would you say it's better or worse than it was, say, 10 years ago?
Well, I suppose it depends who you are. Because if you live in one of those postcodes where you can't get palliative care, if you are socially deprived, if you're a member of an ethnic minority, if you have a non-cancer diagnosis, then you're not going to get very good palliative care in this country. And I think that's awful.
Yeah. So I guess what I'm sort of driving towards, is that simply not having assisted dying, for example, isn't necessary causation for improvement in palliative care in this country, for example. We haven't seen palliative care improve from where it was 10 years ago, last time this debate came to government, for example.
I think the position that we would ask you to consider is this the right time to be bringing in a law to give people a choice for assisted dying when they don't have a choice to have good palliative care?
Sure, and I think that's a really fair argument. I guess what, again, I'm driving towards is that point you were trying to make earlier, I think it's fair to say, which is countries that don't implement assisted dying improve their palliative care system. That clearly hasn't happened in the UK. So what I guess my question, it's not direct causation, is it? There's a number of other factors. I agree with you.
The NHS is very different to any other jurisdiction.
Yeah, so what I guess is the direct comparison isn't necessarily relevant. Is that probably correct?
Can you address it through the chair? It's not a dialogue.
Yeah, sure. Just to kind of drive through.
I understand that, but can you address it through the chair? This isn't a dialogue.
Thank you, Chair.
Thank you, and thank you for the question. Palliative care may well have improved in this country over those years. It has also improved in the countries where assisted dying wasn't available. What we're saying is that there has been chronic underfunding of palliative care, and so where we are at now is inadequate.
Thank you, Chair.
Thank you, Chair. It sort of builds upon that point, actually. That was pretty much what I was going to ask. And that's what I'm sort of trying to get to here. Is that the evidence that we heard, well, not we heard, but the Sue Ryder's evidence to the Health and Social Care Select Committee inquiry into assisted dying gave examples exactly of that, where increases in funding of palliative care came alongside the introduction of assisted dying. So I think you talk about people can't have a informed choice unless palliative care is fixed. Do you accept that the improvements can run in parallel for both assisted dying and palliative care, and that for the small number of people who palliative care can't help and can't, reduce their suffering, that they're left without a choice currently?
I accept that there will be people, even with a very good palliative care system, who would still choose assisted dying. We do not currently have the very good palliative care system that we need, and that's the thing that concerns me.
So building upon that, what would the optimal, what further steps do we need to then improve palliative care, and how do you ever define when palliative care is sufficient to then allow assisted dying? Because that's what I'm struggling with, is how do you say, we've reached that threshold? Is that ever going to be a point where we can say we've got the best palliative care?
So I'll give you some examples of that. We need to make sure that the 75 to 90% of people who are dying that need palliative care are getting it. We need to make sure that there is not inequity in palliative care, that you don't have to be white and rich and have cancer to get good palliative care. We need to make sure that hospitals have 7-day services. 40% of hospitals have no cover 7 days a week. We need to make sure that communities have telephone advice services at night. 1 in 3 don't have any advice overnight for patients and their families to access. So there are some very concrete things that we could change to demonstrate that we are delivering a good service, but currently we're not.
So building upon from that then, obviously we've seen since the assisted dying bill was read at second reading, we've seen announcements from government about investment into palliative care. Obviously that's mostly capital. We need to see more long-term funding. But do you feel that, the point I'm trying to get to here is that we're seeing increases already as a result of this conversation. So is there any reason why that shouldn't continue?
I would love to see it continue. I'm part of the Commission on Palliative and End-of-Life Care. There is no guarantee that the recommendations of that commission will be funded. And that's what concerns me. So I would love to see that happen. Wouldn't that be great if the two could happen simultaneously? There is no guarantee that will happen.
Thank you. Chair, if I may, just on the point that you've made, and agree with Sarah's points. Obviously, we welcomed the government's announcement of the additional funding for the hospice sector, but the committee will be aware that the hospice sector currently receives only about 30% of its funding from statutory sources, and we are therefore reliant on the goodwill of the population to raise money and support us in various ways, and through retail and other ventures that we have. I think the point about universality of service, we have within the Care Act, within the 2022 Care Act, a requirement of integrated care boards to commission palliative care services that meet the needs of their population. But actually, whilst there's guidance in place of what that should look like, there isn't a universal take-up of that guidance and the delivery of all of those services that are stated. So whilst it's outside of this bill, I understand, I think, again, it comes back to that context of how much that overall position can be strengthened across the country. So the context for anybody looking to make a decision is within the same space, and that's what we've said about that Dr. Clark has said around that informed choice. If the context is the same for everybody, then that we can have more confidence that that informed choice is right and at the right level.
Thank you, Chair. Goodness me, there's a lot to cover. I think, to go back to your initial point, Mr Sanderson, in terms of palliative care professionals and what a fantastic job they do, I think it's very important to acknowledge that. And indeed that we're having these conversations, I think, is extremely important. That's why we gave extra time to this particular panel. Just a few points. On Dr Cox, your point about the pressure on the individual doctors who are involved in this process, I think the bill is very clear that if they don't have the specialism, they must refer to a specialist in that condition. And they can refer to a psychiatrist. I think there's probably consensus that maybe we should need to strengthen the bill in that regard, whereas the doubts around capacity, they probably must refer to a psychiatrist. It's certainly something I'm taking away from these sessions. I was very interested in your comments about this multidisciplinary approach. And we've heard from colleagues this morning from social work and from nursing around that. And I'd love to know, Dr Ahmedzai, your thoughts on this idea of a multidisciplinary approach. I think there's a lot of value in that. And Dr Clark, if I may, to you, this concept around training, I mean, I think it worries me that we've seen a very different picture painted by you and others this afternoon from what we had this morning, where we had doctors and nurses telling us that they regularly assess for capacity and coercion. This is a part of their day-to-day work, and they were very confident in their abilities to do that. So I think training is absolutely fundamental. And I think this is an opportunity to look at gold standard training. I'd be interested to know your thoughts on that. So I think one for Dr Ahmedzai and then one for Dr Clark, if that's okay.
So you were asking me about the multidisciplinary nature of this. I'm really glad you raised this, because we seem to be focusing on palliative care as being very professional, and I would remind people that actually there are levels of palliative care, and a lot of palliative care is not given by specialists like the three of us here. They're given by generalists, either GPs, as we've just heard, or by oncologists, geriatricians. And so we'll be talking about increasing palliative care, improving palliative care. It's not just about more doctors like us sitting and giving out specialist level. I think the other thing is, yes, it's not just doctors. We've got to acknowledge that probably in the front line have to be nurses who do so much more than doctors. You know, at the bedside, when doctors clock off at 5 o'clock in those sad institutions that still don't provide 24/7, there are nurses there all round the clock. And then obviously there are social workers, physiotherapists, lots of, and I think it's vital that if we're talking about meeting the needs of people who may not necessarily have pain, but they have other forms of suffering, worries about not even physical, but loss of dignity, loss of independence. Nurses are so good at supporting people in that. A doctor will just get in the way. But actually what we need to do is to make sure that we're addressing the reasons why many people, I know from speaking to people abroad, why they choose, because it's loss of dignity, loss of independence. And isn't that a legitimate reason for wishing that you weren't a burden on somebody, or on the state even? So, yeah, I think it's really important that we consider that. Just the other thing to bring in there as well, if we're thinking about the big picture, I have to say, another elephant in the room is that palliative care is not, strictly speaking, actually in the NHS. Not all of it. A lot of it is outside of the NHS for historical reasons from 50, 60 years ago when decisions were made. And although there are excellent charities providing, discrete areas of it, we rely so much on non-NHS services in a way that you would never think of going to a charity to get your heart transplant or to get your kidney, sort of treatment, dialysis. I think we need to confront the fact that palliative care is fractured because of that history, because of the genesis of how palliative came to be. And not just NHS, but we must think about the multidisciplinarity.
And regarding training and how much it's required, I think that I wouldn't be the first person to make the observation that sometimes doctors can be very pleased with their own abilities at a particular practice, and that practice might be having a conversation where you're assessing someone's capacity. What's interesting as a palliative care specialist is, so I will be asked, my team will be asked to get involved with patients in every possible bit of the hospital, surgical wards, medical wards, intensive care, emergency departments. So you actually see a huge number of patients being treated by many, many different teams, many different doctors, junior and senior, all of whom are having these difficult, nuanced conversations around the end of life with varying degrees of skill. And of course, there are some doctors and nurses who are superbly skilled at having them. And I would say there are many, many who are not. And the reason training is so important is it's a little bit like Donald Rumsfeld's unknown unknowns. You might not even be aware of the fact that you have caused a patient or their family distress, because in a conversation where fear is a dominant part, the patient is fearful of suffering, misery, loss of dignity at the end of life, but they may not voice that. You as the doctor can be completely oblivious of the fact that you've sort of stamped over those unvoiced fears with your hobnail boots. You're not aware of it. And this idea that the patient, a vulnerable patient, needs to be absolutely at the centre of every conversation you're having, I would suggest is quite radical in some parts of the NHS, and it needs to be taught much more assertively from day one of medical school, so that vulnerable patients are always at the centre of the room. And that's why I think the single most important thing for the bill and its safety comes down to training and actually recognising that these conversations are difficult, they are nuanced, and if we assume that, we're going to make sure that a bill is as safe as it can be.
Yeah, thank you. Can I have one quick follow-up, Chair?
Well, I will come back to that if once I get other members in, if you don't mind. Lewis Atkinson.
Thank you. A question to Mr Sanderson and Dr Cox, if I may. Clause 35 of the bill, as currently drafted, introduces a duty on the Secretary of State to report on a periodic basis to Parliament about the accessibility and quality of palliative care. I was just wondered if that's, I think as I understand it, that would be a new duty that's sort of quite pioneering. What your reaction on that would be, and whether you think that would be helpful in continuing the momentum to make improvements to palliative care, and indeed if there are any further reporting requirements as part of that assessment, for example around equity of access that I know some people have mentioned that we could maybe consider when we're considering amendments, etc.
So thank you. I welcome the provision in the report. I think what is necessary is a benchmarking of the current position rather than sort of waiting a significant period of time to do a review. I think we need to benchmark the current state of palliative care and then base, obviously, subsequent reviews on any changes. I think, as I mentioned before, I think we also need to look at the wider context. If we look just narrowly at the provision of palliative care, I don't think we'll properly see what goes on across the whole environment of the health service and in social care as well. We've mentioned about the fact that district nurses, general practitioners are providing a huge amount of palliative end-of-life care, so it may not just be what goes on inside hospices and in palliative care teams in hospitals. And I do agree that I think that needs to look at the demographic information so that we're collecting details on who's accessing palliative care and where and the certain types. I think all of that is necessary as part of that review.
Yes, thank you. I would agree completely about the fact that we need to be doing that review now and in the future regularly in terms of the palliative care aspects, but I also think there's an opportunity to write into the bill other monitoring that would be really helpful in ensuring safety on an ongoing basis. So monitoring in terms of decision making, how often the assessing doctors refer to others, how often they disagree, what happens after the declaration. In the bill there is, as far as I could see, no limit to the delay between the declaration and the request for the substance. So that would be a really interesting thing to look at in the future, wouldn't it? Because potentially somebody could delay 6-8 months, and do we do another capacity assessment then? That's a tricky question. What about the taking of the substance?
Okay.
We haven't talked about that, but I mean I think there's a lot of things that we could look at in the future that would be really helpful to monitor.
So just on one particular point, if I may, I think it's around 650 people currently who take their own lives with a terminal illness, etc. I wondered if there was an element of, if we would see a success of this bill around the reduction of that number going forward, and whether you think that could be incorporated in monitoring going forward, and what opportunities there are you think there are to avoid some of that suffering that clearly people are experiencing traumatic deaths at the moment as part of the monitoring of this bill?
So it's really difficult to know, isn't it, how many people die by suicide because of their terminal illness that would instead access assisted dying. And it's really difficult to understand the impact of an assisted dying legislation on that. If we look at the evidence of suicide, we know that suicide is increased in people with serious illnesses, but it's actually increased in the first 6 months after diagnosis. It's not increased in the last 6 months of their lives. So it's around the trauma of the diagnosis. And what I would say we need for that is we need better mental health services, and we need better support around diagnosis, earlier palliative care. And the other piece of evidence that I would offer to you is that the universal picture, the global picture around what happens to suicide rates when assisted dying legislation is introduced is confusing. It's mixed, but there are jurisdictions, for instance Germany, where after the introduction of assisted dying legislation the incidence of suicide has gone up year on year. So I don't think we can say that introducing an assisted dying bill and legislation will actually stop those suicides.
Rachel Hopkins.
Build on some of the comments around the multidisciplinary teams that you all, do your great work within. The Chief Medical Officer said earlier in one of the sessions earlier about discussions around death and dying and end of life are increasing. They are getting better. But importantly, when we heard from the RCN, Professor Ranger and the Association of Palliative Care Social Workers, they also talked about those conversations they have as part of the wider team, and quite often it's those healthcare nurses having those conversations. And I was really struck by the way they talked, both the RCN around, and you used the word as well actually, not being paternalistic, about having the patient at the centre of that conversation and ensuring we listen to the patient and ask them, what is it you want? And that for me is all about autonomy. Do you agree the emphasis must be on patient autonomy and their choice at the end of life?
100%. And sometimes those of us who work in palliative care almost see the extent to which we try to place the patient at the centre of everything as quite radical when contrasted with a lot of the other medical specialties. You know, my opinion about what's best for a patient does not matter. Their opinion is what counts. And the power of the multidisciplinary team and the reason for thinking it may be worth considering amending the bill so that there is a greater role in the legislation for a multidisciplinary team is this. It's the fact that everybody in that team brings their unique perspective. So whenever there is a tricky issue in my hospital regarding a palliative patient, we will have an MDT, and there may be 10 people in the room all discussing the issues, and this might be someone has decided they want to withdraw their life-prolonging treatments, or they want to have life-prolonging treatment, and for whatever reason it's really complicated. And we will have the patient, their family, doctors, nurses, social workers, dietitians, a big group of people, because that is the way to make the decision most safely and most effectively in terms of enabling the patient to have the treatment that they wish. And it's incredibly important to have that.
Mr. Sanderson to reflect on that for the different context.
Order.
Sorry, Chair.
No. We've got 2.5 minutes to go. There's one other member who wants to ask a question, and with the respect to the member, I want them to come in on that question. Sarah Olney.
Thank you, Chair. Just quite a quick question. It's to Dr. Cox. Earlier on you were talking about in the context of multidisciplinary teams, but you mentioned the family and how important the family of the patient was. There's currently no role in the bill as it's currently drafted for the next of kin or for any family member. I just wanted to ask you, do you think that's a mistake? Is that something we should look to amend?
I think it's a choice of the patient, and it's always a choice of the patient who they want to involve from their social circle, whether that's family, whether that's friends. But I think if the patient wants the family involved, then they absolutely should be, and they should be part of those conversations and discussions.
Thank you. Thank you, Chair.
One last question, very quickly.
Very quick one. You talked about inequality in healthcare and in systems. I mean, what I would like to come back to is the status quo. What are your comments on the inequality that exists currently, where we have assisted dying available to people who have got the money to go to Switzerland and have an assisted death or another jurisdiction? Sam Ahmedzai, maybe first of all.
Yeah. Clearly, we've had that option. You know, British people have had that option for many years since Switzerland offered that. And it's clear that two things that happen. One is it's selecting out people who are better off, more functionally capable. They can do that, so it discriminates against disabled people. But also, people tend to do that long before they need to, when they're still actually fit, because they mostly want to go on their own without dragging relatives along. So it's doubly damaging to families who are experiencing, going through an illness with somebody that's dying, that they have to say goodbye to them long before they ever need to do that. But that's because we do not offer that option here.
Anybody else? Anybody else want to comment, Dr. Cox?
Happy to quickly. Of course, we don't want people to have to make that choice. And I would refer to everything I've said before about, are they making a real choice? Have they had access to really excellent palliative care? I would also make a very brief point about the impact of the discussion about what dying looks like that this bill has raised, and the fact that the stories that have been told have suggested to many of the public that death is inevitably ugly and horrific and dramatic. And actually that's made many people fearful who have been emailing me and saying, I'm now afraid of dying and I wasn't before. And they may then choose assisted dying before they need to, because they have had a fear instilled in them that death is inevitably horrible and dramatic.
But those deaths do
Thank you.
exist.
Whereas actually...
Order. Please. That brings us to the end of the time allotted for the committee to ask questions. I thank our witnesses on behalf of the committee for their evidence. Thank you. We will order. We will now hear oral evidence from Sir Max Hill, former Director of Public Prosecutions, Alex Brooke-Keane, barrister specialising in mental capacity, and Sir Nicholas Mostyn, who is a former High Court and Court of Protection judge. For this session, we have until 4:15 p.m. And we may possibly be interrupted by a division, so just bear that in mind if you would. Could the witnesses please introduce themselves to the record, starting with...
Yes, good afternoon. I'm not sure how much you want by way of introduction, Chair, so please stop me. But I was the UK Independent Review of Terrorism legislation 2017-2018 and Director of Public Prosecutions 2018 to 23, so I stopped 15 months ago. I'm not a campaigner. I'm here to bring any experience I may have picked up along the way of criminal casework, which was part of my diet as DPP. But I have been quite close to the construction of the bill and happy to deal with any questions that I can.
I'm Nicholas Mostyn. I was a judge of the High Court Family Division and of the Court of Protection and of the Administrative Court until 2023, when I retired with the onset of Parkinson's disease, which is a genuine slippery slope, unfortunately. And I'm now a podcaster and devoting myself to alleviating the hardships of people living with Parkinson's.
So I'm Alex Brooke-Keane. I am a barrister in independent practice, and I need to emphasise that I'm giving my evidence today as a self-employed barrister, not on behalf of any organisation I'm associated with. You would have seen from my written evidence I'm associated with quite a few different organisations because my practice and my career straddles both advising and appearing in court cases involving mental capacity. I teach law at the end of life as a professor of practice at King's College London. I'm also very heavily involved in law reform in different ways. I was, for instance, the legal advisor to the Independent Review of the Mental Health Act. I also do an awful lot of training, to the extent relevant, in the context of mental capacity of both healthcare professionals and social care professionals.
Thank you. Now I'll ask members if they want to ask questions. I'd ask Naz Shah first.
Thank you, Chair. Thank you very much. Just one question for Sir Max, please. Sir Max, you have said that you are very concerned about the CPS during your time as DPP having to investigate people who accompanied their loved ones to Switzerland to end their lives. And I share that concern. My understanding is, however, that around half of those who currently visit Dignitas would not actually qualify for assisted dying under this bill because they didn't have a diagnosis of 6 months to live. Is this bill the right measure to solve the problem you're actually worried about?
Well, if the problem is anybody in future going on their own or accompanied by their loved ones to Dignitas, the answer is no. This bill does not satisfy that. But I think what we have learned from other jurisdictions around the world, where we see broader groups or multiple groups beyond the terminally ill who are entitled to use new legislation, that has not been the model for this legislation unless you and Parliament were to dramatically change it. So I think the nuanced answer to your question is that this bill does provide an opportunity for those in the category of being terminally ill, as defined in the bill, to no longer have to resort on their own or supported by loved ones to going to Dignitas. So yes, it can and will make a positive difference. And I should add, if I may, in answering this, that my personal experience, often quoted, is that 27 cases investigated as assisted suicide came across my desk, my own desk, as the DPP, so 5 to 6 a year. A substantial proportion of those cases did involve Dignitas because an accompanying relative who had returned alone was then investigated, but a proportion did not involve Dignitas at all because there had been deaths at home. In all of those 27 cases, I only made the decision to prosecute in one, and that was an individual who was 19 years of age encouraging another teenager to end their life, and that was a correct and successful prosecution. I would also add, though, because until 15 months ago I was a prosecutor, and prosecutors look to bring criminal cases whenever the law is broken, that there were an additional handful of cases in which, although not making the personal decision, I supported authorization of charges for murder or manslaughter in those cases where it was clear that an individual's life had been brought to an end, not at the time of their choosing. And it's perhaps important to remember that this bill, as and when passed, matter for Parliament, would not truncate the homicide jurisdiction in this country. It will still be possible to prosecute for murder in those cases that one would expect to be prosecuted for murder. I feel it's important to say that as a very recent former prosecutor.
Thank you. So just following up on that, the ones that you did authorise prosecution for murder or manslaughter, was there ever issues of coercion involved? What were the bold points, the top lines of those?
Well, it's interesting. Those cases, that small handful of cases, involved an elderly couple where either it was usually he or she, had chosen to bring to an end the life of their lifelong partner, and once that had been done, once that act had been carried out, claimed that it was an assisted suicide in circumstances where the surviving partner was merely carrying out the wish of the person now dead. And there are a handful of cases in which that's clearly wrong, should not be accepted, and murder should be the offence that's brought before the court. The point, of course, though, is that throughout the time I served as DPP, and indeed all of my predecessors, we did not have the coercion offences which are created within this bill, which I would suggest would be a significant advance, nor did we have a legal system in which the investigation was taking place until before the death. It was the other way around. So in each of the 27 cases I considered, the deceased individual was already dead, and that is when the scrutiny started. The major advantage, if I can put it this way, of this bill is that will be reversed, and scrutiny will be before death, and in the case of coercion, where it fits the new potential clauses, prosecutions can, and I'm sure, will be brought.
Thank you.
That's extremely helpful to understand the opportunity for scrutiny before death. And building on that, are there any safeguards around those practices that aren't currently included in the bill but should be, particularly around detecting coercion and exploring alternative care options? And I have one follow-up, if I may.
Well, I think that coercion and the coercion clauses in the bill should be read alongside the capacity clauses, because what we're looking for, and as required by Section 1, subsection 1 and 1.2, is a clear, settled and informed wish, voluntarily made, without coercion or pressure. those are aspects which were taken, at least in part, from the Crown Prosecution Service guidance when looking at 1961 Act cases. But capacity involves understanding information, retaining it, using it, and communicating it. And so if those hallmarks are not there, you may be in a situation where you should be considering coercion. So I think you read the two together. But to answer your question directly, the criminal liability sections, section 24, the new offences in section 26 and then 27, are robust as a matter for your scrutiny. There are aspects that we do not have in the law at present. And there is, of course, the addition of section 36, in which you cannot be a witness or a proxy to the procedure that's enshrined in the bill if you're too close to the terminally ill person. So that is another hallmark of the bill that will hedge against coercion.
Okay, and just to follow up, because it's really important in terms of strengthening the bill, the definitions of coercion, pressure and dishonesty, based on your prosecutorial experience, what key elements should be present in those definitions? And a bit of a technical one as a follow-up, if I may. Do you think they would be better placed in section 26, clause 26, or in clause 40 under the section around interpretation? So the key elements, more that you could say on the key elements of coercion, pressure, dishonesty, and then the placement in the bill so that it's as accessible as possible for all those medical practitioners and patients who will want to rely on it.
Yes, my inclination is that section 26, which is part of the full body of the bill, is the right place for this. But as with the interpretation section in section 40, and as with the way that we interpret statute as a matter of course, there are aspects of other statutory offences or acts of Parliament which help us when we're seeking to determine what coercion is. The creation of the offence of coercion and control, now very commonly used in domestic abuse investigations and prosecutions, has brought us into this territory. And it's not beyond the wit of anybody seeking to use and interpret this bill to also look for other parts of statute which deal with coercion. I'd make the same point about capacity, where what's in the bill is very slender, one might say, because it's inviting the reader to simply look across under section 3 of the bill to the Mental Capacity Act of 2005. But that act is very clear on what mental capacity is and how it is defined. So I think what I'm saying is that from it's a drafting point, and I'm not a parliamentary draftsman, but I don't have a problem with the definition of dishonesty, coercion and pressure being in section 26 where they are, but it's not the only place that one would look. There are other sources available.
And just to push, Chair, on the elements of dishonesty and pressure, you've helpfully acknowledged the link that we need to make on coercion to strengthen this, but on those two other elements, is there anything else that we need to look to make this more robust?
Well, dishonesty is a term of art in common use, but it is also a term of statute. And so anyone investigating or still more prosecuting would understand what dishonesty means. I accept that there's a wider point, not so much for interpretation but for understanding, which this committee may want to consider, of how much of that already existing definition needs to be imported into the bill. But as with mental capacity, I'd suggest, beyond perhaps the odd footnote, it is not necessary for you as a committee to define again what dishonesty means, because we have it elsewhere.
If I could just very quickly add on pressure in particular, I think the committee would be really assisted by having a look at the learning of the High Court judges exercising their jurisdiction under the inherent jurisdiction in relation to people who are said to be violent, to look at people in complicated situations, potentially with impairments, but not necessarily with impairments, where they are caught up, and one person brilliantly described it, being caught in a spider's web. And so those are the sorts of set tools where Joe acceptable, or is it the side of the line we consider to be unacceptable? Because pressure is doing a lot of work there.
Thank you.
thank you all for your written evidence. So Nicholas, in your helpful written evidence, you adopt Sir James Mumby's criticism of the current proposal for judicial oversight, and you instead recommend what you call a Spanish-style specialist panel. I just wondered if you could set out for the committee what you see the benefits of that approach is as to what might be described as the stark judicial oversight of a High Court judge.
Well, if there were how many? 6,000. If 1% would be 6,000 deaths a year. That was 6,000 deaths a year, and if each took 2 hours to process in the High Court, and you've got to read it, you've got to hear the evidence, once one of them has to be oral, and you've got to write a judgment. So that's 12,000 hours. Well, each High Court judge does 1,000 hours in court. I mean, outside court they do lots else. So you're talking about over nearly three quarters of the entire family division doing nothing but this. So it is impossible, in my opinion, for this to be done by the High Court, and it should be done in the Spanish way by a panel set up. As in Spain, the chairperson of the regulator sets up a panel for each case, a doctor and a lawyer. They have to agree, and they check that everything has been done in the person's best interest. They check that it's all been done lawfully. And interestingly, in 2023, 10% extra denials were done by the panel. So I don't know whether that was because they were concerned about voluntariness, or whether they were concerned about suffering, because the criterion is suffering there, but an extra 10% was done by the panel. So the panel wasn't just rubber stamping, they denied an extra 10%. And I believe that an ad hoc system like that, a doctor and a lawyer doing a check, would be the best way of doing it, because the High Court, trust me, I've just come from there, has not got the capacity to deal with this 6,000 cases of this nature.
If I may just quickly come back, and I'll ask Nicholas, apart from capacity, which I appreciate, is there any other problems that you see with the judicial oversight clause? I think it's clause 7. In terms, sorry, is it 12? The relevant 12. Forgive me.
12. You hopefully threw me there.
The clause, apart from capacity, is there any benefit from the Spanish model that you see? And then I'll just, while I've got you, Alex, if I may, you similarly criticise the current judicial provision, and also you say in your very helpful written evidence of paragraph 10 about perhaps we need to consider a multidisciplinary approach, and that's been coming through the evidence.
Can I just answer before he goes?
Yes, I'm sorry, otherwise I'll get cut off, so I was trying to get to
ask the question.
I said earlier on, this isn't a dialogue. Can you address your comments to the chair, and I'll decide who and when people speak. I don't wish to be rude, but everybody's got to have their fair share.
Forgive me.
Yes. I don't know if you've seen Sir Stephen Sedley's memo, which came today, where he has suggested the official solicitor should be the checker of these facts, which seems a sensible idea. The official solicitor would be able to recruit more staff to do this. It wouldn't be nearly as expensive as High Court judges, of course, and it would be an efficient and way of dealing with the problem. The advantage of the Spanish system is you have a qualified doctor as well as a lawyer doing the checking. Remember, a High Court judge is not going to be a qualified doctor, and so that is a significant advantage, in my opinion.
Can I just put that question?
Okay. Kruger.
Thanks very much. I just wanted a quick question for each of you. So Matt, as you point out, the bill doesn't repeal the ban on assisted suicide. And it would still be illegal to assist someone to go to Switzerland. Alex Goodman-Casey, I think, doing an opinion on behalf of Dignity and Dying, the campaign group that champions this bill, in his view, it's more likely that there would be prosecutions for people who assist their relatives to go to Switzerland once this bill was passed. Do you share that view?
I'm not sure about that. I think that in terms of... So I would always default to the Code for Crown Prosecutors and the two tests that the prosecution must go through, regardless of the crime that's been investigated. The evidential stage test sets out what it is necessary to be able to prove to, some people say, a reasonable level, to afford a reasonable prospect of conviction. And one can well imagine that in dignitas cases, that hurdle, that test, is often satisfied. Often satisfied in the cases I considered, could often be satisfied in the future. But that doesn't mean that a prosecution results because the evidential stage test is satisfied, and that's because prosecutors must then go to the public interest stage and consider the non-exhaustive list of factors which are set out in the public interest stage test, together with other policy which, in the case of this area of law, has developed since the legal case of Purdy in 2009, where, in common with many other forms of crime, there are some policy considerations, legal policy considerations, which a prosecutor is entitled to consider. Now, they start at the very obvious. What is the age of the suspect? Because here one's not thinking about the deceased who's gone to Dignitas. What is the age of the suspect? What are their own characteristics? Have they ever committed a criminal offence before? What is their proximity to the case? What motivation did they have, emotional or otherwise, to lend assistance that technically means they've committed the offence? And I'm going through that because I said that a proportion of the cases I considered were Dignitas cases, and it was often at the public interest stage that I determined that a public prosecution was not necessary. And that is because after full investigation it transpired that the surviving relative had acted wholly out of compassion and, may I say, love for the deceased, was not seeking any gain for themselves, far from there being any dishonesty before or after the fact. And that would still remain. So it doesn't follow that were this bill to pass and were people then to take elderly relatives to Dignitas, they would necessarily face prosecution. But the premise to your question is, could they? The answer to that is yes.
Okay, all right, thank you. I mean, Sir Nicholas, you might want to comment too, because if it's and I've got a question for you as well, but I mean, if it is the case that there's more likely to be prosecution, maybe you disagree.
Sorry.
You don't disagree, because in that case, this bill would be worse for somebody in your condition, with your condition, because it doesn't address your condition, and it would put your relatives at greater risk if they did assist you. But you don't think there's a danger of prosecution?
I think it's unlikely. I'm sorry for interrupting you. I always used to say, don't interrupt it. I'm sorry about that, but I fear that I will be, as the lady asked the first question, I fear I will be one of the people who has to go to Dignitas. Frankly, I couldn't afford to do that, rather because this bill is not ever going to be provide an assisted death for me, and I'm not going to be graphic about what the advanced stages of Parkinson's is like, but the medical members amongst you will be able to describe what is likely, not definitely, I don't want to say definitely, but likely to await me. And so it is going to either be a poor death, I'm choosing my words carefully, a poor death here, or to go somewhere like Dignitas. And I would be extremely surprised if my children took me as far as Calais. Of course, but they helped me after Calais. The assistance only applies to within the jurisdiction. If my children take me to Calais and then drive me on to Zurich, I would be very surprised if any prosecution ensued. Very surprised.
Thank you very much. Just because time is tight, I wanted to follow up further, but I'll just jump to Mr. Rutkin, if I may. Could you explain a little bit about your concerns about the Mental Capacity Act and its interaction with this bill? Do you think the threshold of capacity is adequate that's set out there?
So I think there are two different questions, if I may. One is any idea of capacity sufficient at all? I think that's an existential question which I'm just going to park, if I can then turn to the Mental Capacity Act itself. I think it's important to understand there are three different bits to the Mental Capacity Act in play. So we've got a set of principles. So the presumption of capacity, the presumption you have to provide all practicable support before you find someone to lack capacity, and the idea that you can't, just because a decision seems unwise, you can't say that someone lacks capacity, so you've got that. Then you've got a functional aspect. So in other words, can you understand, can you retain, can you use and weigh the relevant information, can you communicate their decision? And then you've got what some people call the diagnostic element. In other words, is there an impairment or disturbance in the functioning of the mind or brain? So there are three separate things, all of which we make work more or less in everyday practice. I should say more or less. I was on the advisory group for a project funded by the National Institute for Health Research yesterday, funded in 2022, to try and increase the quality of mental capacity assessments in the healthcare setting. So I think we need to be under no illusions about how well we're doing it at the moment. but we make it work more or less. But the Mental Capacity Act works more or less in the healthcare context because every time we reach the view that someone can't make a decision, we've got an alternative. We can think about best interests. What we're asking the idea of mental capacity to do here is different, because there is no suggestion that if you can't support someone to make a decision, will ever make a best interest decision in their name to assist death. It's also not obvious that the idea that a presumption of capacity should apply. So if I doubt that you have capacity to make the decision to take your own life or end your life, but I can't prove it, is it logical or are we required to proceed on the basis that you do? And also, it's not immediately obvious that it's right that the diagnostic test applies in this context. So in other words, I think you can't understand the information, but I can't prove the reason you can't understand it is that you don't have that you've got an impairment or disturbance. So I think that's where my concern when I was explaining it in my written evidence comes in. But can I be absolutely crystal clear, totally crystal clear? As far as I'm concerned at this stage, this is policy development. I'm so glad that evidence has been taken and the public bill is drafting, or is thinking about this. But a bill of this nature needs to be drafted by Parliamentary Council. So what I'm really trying to get across is the policy line. And to me, the policy line is what doctors need to be interrogating, and anyone else, because I would love it if other people were involved, is that what doctors are interrogating is, can the person understand the information? Can they retain it? Can they use and weigh it? And can they communicate their decision? And if they can't, we don't need to start mucking around with why not. It's just that they can't. And so that is the central idea of capacity, the functional idea, but it's tooled for use in this Act, rather than, as it stands at the moment, just being cross-referred out to the Mental Capacity Act and raising a whole series of additional complexities. And my only other observation is I spend an awful lot of my life trying to improve Mental Capacity Act practice more broadly. I would be massively, massively concerned were a knock-on effect of this bill seeking to deal with a very specific group of people to start inadvertently, and it would be inadvertently, interfering with how we think about healthcare decision-making more broadly in the context of those people with impaired decision-making capacity. So it's an insulation point, this is the right, making sure you've got the right tools for the job point, and it's not having a knock-on impact on thinking about things more broadly point. Sorry for the long answer.
Thank you. I'll move on. You can maybe pick this up, but I'd move on to Sojourn Joseph, because we have 8 people wanting to ask questions with half an hour tops. Sojourn Joseph.
Alex, thanks for the written statement. And with your experience in capacity assessment, we heard from the previous panel, especially from the practicing Dr. Clark, how complex it is, and she was explaining how she don't think everyone has enough training in capacity assessment, and it's so complex in the NHS healthcare areas. So your observation about a multidisciplinary involvement in, rather than 2 doctors, do you think that can strengthen this bill if we have more than 2 people involved in that decision making?
Well, I think for many reasons it can, because this is, on the pure capacity side, this is at one level an existential question. This is not a healthcare decision, it's an existential decision. And so the more insights we've got from the more people able to bring their different perspectives, the social work perspective on the person's social circumstances, the medical perspective on the medical condition. So we've got as many eyes on the person as possible and insights into the person as possible. So it's trying to make sure that the decision goes back to, are we really satisfied that the criteria set out at the beginning of the bill are met? So I personally think having MDT, so multidisciplinary, for instance, as you would have in the Mental Health Act detention, we have more than one pairs of eyes on for more than one discipline.
Thank you.
Thank you. Sir Nicholas, I'm going to paraphrase a little bit, but you did say people with Parkinson's will never get a terminal diagnosis, so this bill is no use to anybody, or so no use to us at all. I think you used actually quite a lot stronger language than that when you made your original statement.
Well, I was sort of taken by surprise when she asked me the question in the pub, and I wouldn't have phrased it like that in Court 50.
No, sure. Let's phrase it in a different way then, shall we, today? But would you be able to expand a little bit on your thinking there?
Yes, I mean, Parkinson's is such a complex condition. I mean, there are so many, the medically qualified amongst you all know this. There are so many ways, so many symptoms, and the rate of development, the direction of travel. It is an enormously complex condition to know, and that is why it is commonly accepted that you do not die from Parkinson's, you die with Parkinson's, and it's impossible to give a mortality rate as to when it's likely to happen. It's almost impossible. Mind you, when I was doing my research, I was slightly surprised to see that last year 6,000 death certificates had Parkinson's written on them. But they do say that the experts in Parkinson's are the people with Parkinson's, but the people you talk to are quite clear that it is impossible to predict. It's a really complex thing. And so that is why this arbitrary, and I use the word technically, arbitrary 6-month period is never going to be, if a doctor opines conscientiously and honestly, it will never, unless the Parkinson's patient has already developed pneumonia or sepsis or something of that nature, which is other common, or complications from falls, the common reasons for death, you're never going to get that 6-month ticket. That's the thing, that's the problem.
Thanks, Chair. And so, in your view, I think you kind of said it before, and I hate to put words in your mouth, but are you saying that Parkinson's sufferers and other similar
neurodegenerative,
are kind of left out of this debate?
Yeah.
And in view of yourself and indeed the rest of the panel, is there a way to legislate?
Well, I've been, if I might answer that, it's been suggested I want to expand the definition of terminal illness. I don't want to expand it. I want to redefine it so that it is more appropriately focused, in my opinion, on what this bill should be about, which is the relief of suffering. That is what I believe this bill should be about. And you should get the permission to have an assisted death if you are suffering intolerably within 5 months of death or 7 months of death. And there shouldn't be this arbitrary line. Moreover, it shouldn't be open to people who aren't suffering but who happen to have a 6-month life expectancy. There are probably quite a few of them, for one reason or another. Their life expectancy is short, but their pain is being well managed. I don't believe that the assisted dying should necessarily be available for them. I do believe very strongly, and this is not an expansion, but in my view a more appropriate, focused redefinition of terminal illness, that it should be, as in Spain, as in Holland, focused on suffering.
Rebecca, Paul.
Thank you very much, Chair. My questions are to Alex Ruck-Keene. Thank you so much for your written evidence, which I read with great interest. I've just got 2 points, 2 questions for you, and it follows on nicely from the discussion we've just had now. So the terminal illness definition, is there any risk that if that were to remain in the bill, that this could be challenged under the ECHR? And then my second question, which is completely different, just to mix it up, is you made a really interesting point in your written evidence about we need to give consideration to the National Suicide Prevention Strategy. And I find this really interesting because potentially this bill turns on its head the way we view suicide, and obviously we've been sending a certain message out there, particularly to our young people. Could you elaborate as well on the point you were making in your written evidence for the committee?
Gosh, yes. So there is absolutely no way you can stop people trying to challenge whatever bill, whatever act is passed. There's no way you can stop people seeking to challenge that under the ECHR. We then get into this enormous argument about, is it inevitably discriminatory? And courts today have been very clear, we're not going to get into this. It's for Parliament to decide whether or not to make assisted dying legal. Once it's made legal for some people, but not for others, there is a difference in treatment. Whether it is discriminatory, and therefore contrary to Article 14 and 8 and 14 of the ECHR, depends on whether that difference is justified. And so what I was trying to be very careful in my language, because I try to be careful in my language, what I think the Bill Committee needs to do, and Parliament needs to do is be very, very clear why, if you are going to limit this, because if Parliament does limit it to a cohort of people, and I feel acutely conscious, I'm sitting next to somebody who would be excluded, why it could be explained to somebody that you are not eligible, and that is a difference in treatment, but it's perfectly justified. If you can't do that, that will be discrimination. And the courts have been very clear, if you're going to have a system, for instance, it benefits, social security benefits, you don't have to have one, but if you're going to have one, you have to have one which is non-discriminatory. So that's the answer I can give to that. And the one thing I can say is you can't stop lawyers trying to challenge. And that's what they will do.
All laws discriminate. All laws discriminate. 69 miles an hour is not an offence, 71 is. I mean, all laws discriminate. The question is whether it's justifiable.
And it's also a question of providing legal certainty, which is why the definitions in the bill are so important. But provided that is articulated clearly, and it's within what the European Court so often calls the margin of appreciation, which it gives to sovereign states, and although I agree with Alex that a challenge may be possible, I cannot see a successful challenge to the bill if drawn in the sorts of provisions we have here. And indeed, we haven't seen local nation-state examples of this sort being struck down by the European Court elsewhere in Europe. So I think it's very unlikely that we'd see such a strike down here.
I really hate to get into with such eminent lawyers. There hasn't been a case in Strasbourg seeking to say that a limited class of case is discriminatory, so we just don't know. And I think to some extent
I agree with that. I've changed my mind twice about this subject. So.
Thank you. Do you mind if I just very, very quickly touch on that?
Not just for the moment.
Of course.
Daniel Francis.
Thank you, Chair. So, Alex, if you could also, in your written evidence in paragraph 8, you touch on clauses 9, 15 and 18 of the bill and the potential complications that could arise when the substance is taken. And I just ask if you could expand on that slightly and the concerns you have on that element.
So my concerns arise here because, and I totally, and I should make it absolutely clear, all I'm trying to do is try and make sure that whatever law is passed is a good law and has as few inadvertent consequences as possible. My concern arises out of the fact that, understandably, the proponents of the bill want to make it very, very clear this is about people carrying out the final act. And no doctor is allowed to do something which involves going beyond that. But at the same time, we have a situation where doctors, I'm using the word doctor slightly loosely, but that's, for present purposes, that's what we're talking about. The doctor has to be present and has to remain with the person. And we know that there will be some people for whom there are complications. And my concern is to make sure that there has been sufficient consideration given as to what exactly a doctor is meant to do at that point. Because it seems to me that that ends up putting the person who is undergoing those complications in a horrible position. It is also, and I'm perfectly happy to use this phrase, putting the doctor in a position of extraordinary moral distress. Are they then at that point supposed to try and rely on the doctrine of double effect and say, all I'm trying to do is treat the complication, I'm not trying to bring about your death, but the bill is saying, no, you're not allowed to do that. And so it seems to me that I understand entirely why the intention is to say doctor must always be, as it were, hands off, but you need to be super clear. You're going to put some people in some very, very, very difficult positions, and Parliament needs to be very, very clear-eyed about that.
Thank you, Chair. And I just want to stick with clause 18, if I may, because as it currently stands, there can be some assistance by the clinician, but there can't be total delivery or administration by the clinician. So you could end up with a scenario whereby, for instance, you have somebody who's tetraplegic, who then gets a terminal diagnosis, they have capacity to make the decision, they want to end their life, but they don't have the physical means of doing so. Do you think that's open for challenge? And I'll start with Sir Max on this, on grounds of discrimination.
I wouldn't look at it on grounds of discrimination. What I would do is put that clause alongside what are generally referred to as the slippery slope arguments in other jurisdictions. And in other jurisdictions, Canada might be one, some of the US states might be another. The provision of life-ending medication is expressed in a form of treatment by a doctor. This is not that. So we're clear, I think, when we're reading Clause 18, that this is not a permission to administer. In fact, it's a prohibition on administration. It is making available in certain tightly defined circumstances and then standing by, not necessarily in the same room, subparagraph 10 of paragraph or clause 18, whilst the self-administered medication takes effect. Having said that, I am absolutely clear that there is so far that a bill or an act of Parliament can go as primary legislation, and there is then further distance that must be covered by the provision of practical and professional rules here under the auspices of the National Health Service to indicate precisely the circumstances physically in which this will happen. I don't see that as discriminatory. We're dealing with a tight category of defined individuals to whom this does apply, and it doesn't apply to anybody outside that. We've just discussed that. But it is not prone to the slippery slope arguments of something that is generally to be made available in the course of treatment. In fact, the bill's been couched in a very different way.
And can I just bring Sir Nicholas in on that? Because you refer to it directly in your proposed amendments.
I do. I mean, what particular aspect do you want me to address? There's been ranged quite wide. I mean, in relation to the administration of the substance, it's interesting in Spain, which is now in its second full year of doing this, that take-up has been extremely low. Only 700 requests, quarter denied, quarter of the people denied died prematurely, 300 were granted. But of the 300 granted, 95% of them were administered by the doctor, and only 5% were auto-administered. So I'm trying to work out culturally in Spain why maybe people go when they're extremely infirm, and that's the reason for it. But I'm not able to see the moral distinction between between having it administered and doing an auto-administration. And the question that you asked, I mean, I think there are devices which enable somebody who's locked in to end their lives by a blink of the eyelash, yeah. But aren't there? Yeah.
I'm grateful. Thank you.
Thank you. We've heard from two witnesses now, Sir Nicholas from you and from Dr. Ahmedzai from the earlier panel, around this question, particularly around the judicial oversight. I just want to, while we've got Sir Max here and Mr. Rakeen, about your observations around the proposals from those two witnesses that an alternative to a High Court judge overseeing that process would be some form of panel or tribunal, potentially multidisciplinary. Can I just ask, while we both go through here, about your view on that and the legal implications for that?
I think I'd say two things. Firstly, it bears weight that looking at all the provisions in this bill, the additional level of scrutiny that is currently being called judicial scrutiny or approval is absent in all the comparative examples around the world. So that makes this already a tighter pre-legislative model than we see in other countries that have gone down this route, and that's worth remembering. But secondly, whilst I'm not a family lawyer, at least I was, but a very long time ago, whilst I do think that the family division of the High Court would be very well placed to perform the sort of exercise that's enshrined in current drafting, which is not a rubber stamping exercise, but is a substantive consideration of heavily objective medical opinion arrived at by not one but two doctors, one of whom is not the treating doctor. I, of course, listen to and accept the question of pressure on the justice system generally. And that is something which this committee will be concerned about, because we want something, if passed, that is workable. So I heed what James Mumby said. The sitting judiciary, for good constitutional reasons, are highly unlikely to say anything. But I do think, therefore, that there is merit in looking at Clause 12 and performing actually quite a simple exercise under the heading Court Approval, which for me would be to go through subclauses 1 to 6 inclusive of Clause 12, and on each occasion where at the moment it says High Court, replace it with something else. Personally, I have an aversion to the word tribunal. which indicates a sort of right and wrong, some kind of fault-based system. That's not what we're talking about here, but a panel, as Nick said,
appointed by the official solicitor.
is the way to go. Whether appointed by the official solicitor or not, dare I say it, because I'm sitting next to a very distinguished one, I do wonder about the recently retired judiciary and the role that they could play under a replacement panel system.
No, but that's what I had in mind, the official solicitor looking at the retired judges.
Yes. Yeah. So there is capacity there in terms of legal professional capacity amongst the retired judges. Not that they would sit alone on a panel. It would bring with it the extra benefit of having suitably qualified medical professionals like the Spanish model. So yes, I do think that could be done. That's not the same thing as saying the High Court approval model is fatally flawed and couldn't be introduced. But I do think there's a viable alternative which is worth looking at.
My only observation, and I said it in my written evidence, but I do just want to say this out loud. I do think you have to think very carefully about what purpose any form of this oversight is actually serving societally if the oversight panel, whether that be a judge, whether that be a panel, can't decline to approve an application if they consider that the reason the individual is seeking assistance in dying is because of service provision failures by statutory bodies responsible for meeting their health and social care needs. That is a question of principle, and I just want to make sure that is squarely before you.
Thank you. Liz Saville-Roberts.
A question to Alex Keane, please. And I noticed your comments in your evidence about presumption of capacity, concerns over that, and I know that you've written in the past as well of concerns of different disciplines in relation to different disciplines having different definitions of capacity. You also say later on in your evidence that multidisciplinary consideration of the circumstances in assessing eligibility could be what I would like to raise is how that having that multidisciplinary eligibility assessment might alleviate some of your concerns in relation to capacity decisions.
Well, I think it's partly because it's making clear, that we've got capacity, but we've also got to make sure it's settled, we've also got to make sure it's informed, we've got to also make sure it's voluntary, and we don't have things like pressure or influence going on. So I think it's important to make clear, I'm not just saying this is about all the weight going on capacity. But, for instance, if you've got social workers involved, you've got palliative care social workers, say, involved, assuming this is a palliative care situation, they are going to be far better informed about what options might be out there than a doctor, potentially, depending on the doctor. Social workers, more generally, might well have expertise in picking up signs of coercion or signs of influence than a doctor. But I really don't want to necessarily get into some disciplines are good at X, some disciplines are good at Y. I've come across brilliant examples and bad examples in both zones. So it's partly the multidisciplinariness and the very fact if you've actually got more than one person trying to talk it through, because in every single, I always try and tell people when I train, 85% of capacity assessments aren't all that difficult. They're just made difficult because you don't have time or you're not listening. But it's the 15% are more difficult. And I think a lot of these will be into the 15% zone. And into the 15% zone, the more people you can have thinking about it, so long as they've got an agreed framework within which to think, the more reliable, the more transparent, the more accountable the outcome's going to be.
Thank you, Chair. Just wanted to pick up on your evidence, Sir Nicholas, in relation to the panel that we've just been discussing again with Sir Max. 3 questions, I suppose. Firstly, what do you envisage under your model that the panel is doing? Is it ensuring that a lawful process has been followed, or is it doing something more than that?
Former.
The former, that's helpful. What information, secondly then, do you think the panel needs in order to reach a determination on that
Well,
question?
it's going to have the statements in Schedule 1, 2, 3 and 4 signed by both doctors twice. And then the panel, this is where it gets slightly tricky, because is the panel expected to be a ferret? And to ask, this doesn't quite chime for me. And I think this is something that the committee is going to have to consider, is that how investigative the panel is, or is it going to be purely just sit back and accept passive and just work on the material it's got, or should it does have to, of course, under section clause 12, it does have to hear orally, doesn't it?
That's right.
And so that might get the alarm bells going. But I believe that the panel should be entitled to call for further evidence if it's got concerns.
And I
I mean, as I say, I've been trying to find out why 10% of them were rejected by the panel in Spain. There must have been some kind of procurement of further evidence by the panel in order to do that.
Yeah, and I suppose my third question then is how would you envisage such a panel, if at all, interacting with the High Court, say, a final right of appeal to the High Court, similar to what you've got in the bill?
Article 10 of the Spanish law gives an appeal on a point of law to their High Court. So I would have the same, an appeal on a point of law to the High Court, only on a point of law.
Either way, it would have to be either way. It couldn't just be against a decision not to approve. I think that logically, because it'd be very. I mean, the current model is very odd, saying you can only appeal one way from the High Court.
Yes, I mean, Spain gives either side the right to appeal, so I agree with that. But it's confined to a point of law.
And Chair, can I see if Sir Max wants to come in on any of that?
Yes, I would only add, I wonder whether that is the only route through, namely leaving open a judicial review appellate process, or whether, for example, as we imagine with a number of commissioner-led processes already in this jurisdiction, the panel, or actually, frankly, I suspect panels, plural, who might sit regionally, chaired perhaps by the retired judiciary, would have an appellate route to a national body, you could call it a national commission, instead of a judicial review route to the court. So there are a large number of commissioners, some sitting under the Home Office, some sitting under the Ministry of Justice. In a sense, I was a commissioner when I was the independent reviewer of terrorism legislation with closely defined powers. There are many others who sit in an enhanced regulatory position, highly qualified individuals who you could describe as a national commissioner, if that's an appropriate word, who would have superintendence over regional panels, the power to appoint retired judiciary, perhaps with the assistance of the official solicitor, to sit on those regional panels, and then to have an internal appellate mechanism.
I mean, you have to have an appeal process of some type, because otherwise there'll be judicial review.
Yes, I
agree. If there's no appeal, there's judicial review. So you have to have an appeal of some type, or there will be judicial review.
Thank you.
If we want to ask some more questions, we've got about 6 minutes or so. Jake Richards, you did have a possible question.
Some of it's been asked just on that point, just exploring this appeal. If it was, as Alex
pointed, either side could appeal. Who would be appealing against a decision to allow assisted dying?
Oh, I mean, the relations who say my father has been pressured by his new wife to do this, and a child's objecting, father's given permission, and the child who's asked to intervene is joined. There would have been some process where the child would have been allowed to become a party to the proceedings, because that will have to be specified in rules, and then that would be that person would be the appellant.
Just the bill at the moment doesn't provide for, and for good reason, but potentially doesn't provide for family members receiving notice of this.
Well, it does.
Autonomous decision. So
no, but it says procedure. They can determine its own procedure.
Yes. No. Sorry. I meant that in terms of.
Sorry,
Chair.
I really am giving you an opportunity to ask a question. So ask the question, and we'll get the answer back, and then we're going to move on. I don't want this dialogue, I'm afraid.
Forgive me. Sorry, Chair. I meant in terms of the assisted dying process, there is no automated mechanism for family members, or indeed any third parties apart from the doctors in the bill, to have notice of this intention. Is there a concern with regards to this appeal point that perhaps interested parties would not know?
I'd suggest the key to this is in clause 12.5, and that's why I've recommended just striking out the words High Court and putting in the word panel, and then reading the whole of clause 12 as amended, with those situations in which there are steps which must be taken, and there are many, and those in which there are steps which may be taken. And in 12.5 here, following the logic, we'd imagine that a panel, just as the High Court, may hear from and question in person the person who made the application, but must hear from a coordinating doctor. Now, the appellate mechanism, which I agree there needs to be, will be looking sharply at the operation of that subsection. In other words, when the panel made its decision to refuse, on what basis did it make that decision, and from whom had it heard? We can well imagine situations in which a coordinating doctor, having taken his or her own steps to ascertain the views of the nearest and dearest, would satisfy the panel as to what the views of the family are. The reverse of that is there's no indication here, this has gone all the way through the panel process, no indication that the family have been made aware or considered at all. I would think that's going to be a rare scenario, but I'm not a medical professional. But I think you can cover that, perhaps with some changes here or there on what you impose on the panel as a mandatory duty and what you leave by way of discretion, subject to the rules of procedure that the panel would then adopt.
Thank you. This is for Sir Max Hill and Alex Rook. Your insight on Clause 12 has been really helpful. What procedures would you recommend being adopted for testing and, if need be, challenging the evidence as part of an evidentiary process linked to the panel you've set out?
Thank you. This is for the moment predicated on the fact we're still in the High Court, as opposed to slightly making up policy on the fly about a panel. Assume it's the High Court for a second. It seems to me the High Court has got to be discharging a properly inquisitorial jurisdiction, which means it has to be armed with the tools to do that, which includes arming it with the tools to call for its own evidence, and it also seems to me that the High Court being armed with its own ability to not just receive evidence from one side and have someone testing it, which then brings you to the only player in town who could possibly do that would be the official solicitor as advocate to the court. And I don't want to emphasise too much the question of resources, because if Parliament thinks this is sufficiently important, the resources will be voted through. But it is vitally important to note the official solicitor is completely overloaded. And asking the official solicitor to act as advocate to court in every single one of these cases, and you couldn't have it optional. You can't say, well, it's some and not others. If it's going to be inquisitorial, the High Court's got to have the ability to say, this is one-sided, someone needs to tease it out. So the official solicitor would have to be funded to be advocate to the court and, if necessary, instruct lawyers in every single case.
Max.
The model that I was espousing would not necessarily involve the official solicitor at all. It would make no draw on the administration of the court or any officer of the court, still less full-time judges. It would allow the appointment of recently retired judges, as we have in a number of scenarios, surveillance commissioners, for example, and a fresh administration. With that, as with the High Court model at the moment, there's the primary set of provisions which Parliament must impose, and it's important that that provides sufficient for what Alex called an inquisitorial function. In part mandatory, those things that the panel must be satisfied about, and they're set out in subclause 12.3, and then those that are discretionary set out in subclause 12.5. But what sits between the two is very important here, currently expressed as rules of court, but it would be rules of the panel or the commission that appoints the panels. In a court scenario, we're all familiar with criminal procedure rules, civil procedure rules. That's the secondary stage that is reached once the primary legislation's been fixed. That too would apply on the commission or panel process. But as I say, I don't think necessarily it would involve using existing paid judicial resources at all.
That's extremely helpful, thank you.
Thank you very much for that. Unless there are any more pressing questions, I think we have 1.5 minutes in. It literally will be a 10-second question and a 20-second answer. Unless you can do that, I'm going to call it to a close.
Go for it. So Nicholas, great sympathy with your position. However, how would you frame this law so it would cover yourself?
I would frame the law to define terminal illness in the way that it's defined here in its first part, but in its second part, I would substitute where the person's death in consequence of that is. I would delete but subclause B and substitute suffering intolerably.
Thank you. Order. That brings us to the end of the time allotted for the committee to ask questions, and I thank our witnesses. on behalf of the committee and for your forbearance. Point of order.
Thank you.
Sarah Olney.
Up at the very beginning, I'm really, really keen to ask a question in this session because it's pertinent to an amendment I myself have laid. How could you advise me to make sure that I've got the opportunity to ask my question?
Well, I'm more than happy to speak to you afterwards, but I've got to say, we had lots of questions today. I was trying to get people in as much as possible, and there has to be an element of self-discipline from people asking the questions as well and interrupting. So I'm more than happy to facilitate if I possibly can, but I'm afraid there's a responsibility on members also to look to other members' needs. Thank you very much for your evidence. Thank you very much.
Was asked or answered. Can I just get it in writing? Is there a formal way to do that? I'm very happy to do it in writing.
Well, there might be. I think it's just read once, so we can give you a.
No, but can you do it?
But there might be.
Obviously, it's just they got excluded by ECHR. Distracted.
Well, they. You've got the witnesses in? Yes. Oh, sorry. Do you want to bring the witnesses forward? Who's bringing them up forward? Oh, sorry, okay. Sorry. Order. We will now hear oral evidence from Dr. Ryan Spiegvogel, who is Senior Medical Director for Aid in Dying Services for Sutter Health, California, and Dr. Jessica Khan, who is Medical Director for End of Life Washington, both will be via Zoom. I call members to ask questions, but in view of the last point of order, can I be absolutely clear? I will ask members, and I will interrupt if necessary if questions are too long to the witnesses. We don't have much time. People do want to get their questions in, and there has to be that element of self-discipline in that regard. Kim Leadbetter.
Thank you, Chair, and I will try and be brief. Thank you for joining us from wherever you are in the world. It's great to have you with us today. I'll get straight to the point. There's understandably a significant amount of nervousness about the potential change that this bill would create within England and Wales. Could you talk to us a little bit about what the process has been like in your jurisdictions and what it looks like now, your experience, but also maybe particularly focusing on questions around mental capacity and around coercion? Dr. Spiegvogel, maybe first.
Yes.
You're on mute.
I'm afraid.
He's unmuted, but we can't hear him.
Just bear with me, I'll mute. Can we just check?
Can you hear me now?
Yes.
Thank you. Go ahead. Thank you.
After several years, you'd think I'd get this right. Hi, members of the committee. Thank you all for having me today. So yes, I'm Ryan Spiegvogel. I'm Senior Medical Director for Assisted Dying Services for Sutter Health in California. I have been an assisted dying physician for the past 8.5 years since the law went into effect here. And so I've seen many terminally ill people going through the process. And you asked specifically about coercion and capacity, is that correct? So determining mental capacity is something that we as physicians do every day. There are codified steps and processes for us to be able to assess a person's capacity. Capacity for anything, any procedure, medical intervention, anything is presumed that the patient has capacity until they are deemed to not have capacity. And we do that through asking questions, determining their understanding of their disease process, asking them to repeat what their understanding of their options are, making a decision, and then telling us their judgment as to why they were coming to that decision. So that's something that we do every day. It's oftentimes informal. If I'm, for instance, prescribing someone a blood pressure medication, I might not go through the entire process of assessing capacity, but in longer or in higher stakes kinds of conversations, like end of life discussions, I usually do ask somebody to repeat back to me what it is they understand of their disease process and their options, what their decisions are, and why they are making those decisions. And that's basically exactly what I do in these conversations. In terms of coercion, I understand the concern. It is a very valid concern that people have. I have seen this now in many jurisdictions in the US where they are where different states are considering legalizing assisted dying. But I'll tell you, in practice, it just doesn't happen. So I've seen assisted dying laws go into practice across numerous states, and I have helped many, many people through this process, and I have never seen a case of even where I suspected coercion. People are just not that good of actors. So we get the family out of the room, we dig deep into their concerns and their justifications and the reasoning behind their choices. And it is often extremely crystal clear when you are speaking to someone who is suffering from some terminal illness. They are very focused on their symptoms, they are very focused on their quality of life, they are very focused on their suffering. I don't ever get the sense from them that their family or their doctors or anybody is coercing them into the decision. In fact, if anything, I've seen it many times the other way around. I tend to see where the patient is really ready to let go and the family is really not ready to let go, and the family puts up varying degrees of roadblocks to the patient accessing assisted dying. So I've seen many cases of people being coerced out of it. I've never seen someone being coerced into it.
That's incredibly helpful. Thank you.
I'll stop there.
Thank you. Dr. Khan, do you want to add anything to that and maybe touch on the training that takes place around identifying these things and those conversations that take place?
Yes, I would echo exactly what Dr. Spielberger has said here. We are trained as part of our medical training to assess capacity, both in small ways and in big ones, depending on the size of the decision at hand, which, as he said, throughout our medical training, this is something we are trained to do and to continually assess at, progressively with a patient over time as we're seeing them in subsequent visits as well. And so this is really not different from that, although obviously the stakes are a bit higher than, as he said, a blood pressure medication discussion. But really looking at, are they able to voice a reason for making their decision? Do they have a logic behind it? Do they have a set of values that they can express? Is their decision consistent over time? We're looking at a longitudinal assessment rather than just one fixed moment in time. And over the course of our assessments, it really does become clear in almost all cases that somebody either does or does not have the capacity to make this decision or any decision. And so this is really not outside the realm of what physicians are trained to do in any other case of medical decisions, especially large ones. And in the case of coercion, I agree that virtually all of the time, I would say that it's the opposite way, where people and family members, loved ones, well-intentionedly are trying to coerce or convince someone not to make this choice or not to proceed with this option. They may have it available, rather than them pushing them to actually do it. But I think the way to properly assess that is to ask open-ended questions, to, as Dr. Spielberger has said, have them in the room alone, at least for a portion of the assessment, so you can have a one-on-one conversation, ask the questions in various ways, and so you're seeing the consistency of answers over time, as well as looking for non-verbal cues that may indicate, that something else is going on. And so I have also never come across a case where I felt that a patient was being coerced into this decision by a family member, but rather the opposite.
Thank you.
Thank you. My question is just about how it's going, how you've implemented it, and what changes you've made from the start when it began to now, what sort of teething problems you found as you were going along, and what adjustments you made to your process. So Dr. Spiegelfeld first.
Thank you. So the original version of what's called the End of Life Option Act, which was the bill that legalized assisted dying in California, when that went into effect in 2016, it then was amended in 2021, I believe. And those amendments, the main one that did was it shortened the waiting period. So there was a 14-day waiting period, mandatory waiting period, between two verbal requests that a patient would give directly to their physician. And what we found when we were studying it was that approximately 30% of people died during the waiting period. And after many conversations with patients where the waiting period and the thought process behind it is that somebody is making a persistent and well thought out, non-capricious decision when they're asking for this. But there is a false premise in there.
Sorry, Doctor, we have a vote in the chamber, so we will have to suspend the sitting for 15 minutes. So we'll be back in 15 minutes time at 16:40. And please bear with us while we carry out the vote. Thank you. Order, order. We now resume the sitting, and we were in the middle of listening to Dr. Ryan Spielvogel speak to us. So, Doctor, if you would like to pick up where you left off, so to speak.
Yes. So I'll make it brief. I was saying that it's an erroneous assumption that people start thinking about assisted dying the first day that they give their first verbal request. In reality, people have been thinking about it usually for weeks before that visit. And so because of that, we didn't actually see anybody's decisions really ever change between the first and second verbal request 14 days later. So that and the fact that 30% of people were dying during the waiting period led us to shorten the waiting period to 48 hours. That's the main change that we've had in our law since it was implemented.
Thank you. And the same question to Dr. Khan.
Yeah, so you obviously know that throughout the United States there are a variety of aid in dying laws, all of them slightly different across jurisdictions, and I actually practice in both the state of Oregon and the state of Washington, so I have to kind of keep track of two slightly different laws. But in the state of Washington, where I'm the medical director for End of Life Washington, in 2023 we did update our law, mostly because we were trying to increase access to this law for people who lived in rural communities or for people in underserved communities. As any healthcare system, I think, in the world right now has experienced a shortage of physicians, and so the requirement that it be two physicians doing the certification was a barrier for people in those communities that did not have access to two physicians. And so one of the things that we did to increase access in 2023 was to make it so that one of the two providers could be a non-physician, so a physician assistant or a nurse practitioner with advanced training could be one of the two providers. Now, one of the providers does still need to be a qualified physician, but that has increased access for those in those communities that I've mentioned, rural communities and underserved communities. And so we're very proud of the fact that we've done that. And additionally, we also shortened our waiting period for similar reasons from 15 days it was, and down to 7 days now. And in Oregon, they shortened their waiting period. Well, they have still a 15-day waiting period, which has been stable since the start in 1997. But they also now have a provision where if a patient is expected to die within those 15 days, that they're at the very, very end of their life and they're expected not to be able to survive those 15 days, that they can actually bypass the waiting period. And I really like that provision because there are patients who come very late in their process to this decision. And it may not seem like much to us who are healthy and relatively well, but 15 days for a dying person who's suffering and really wants this option is an incredibly long period of time. So,
thank you.
Thank you. Tom Gordon.
Thank you, Chair. It's been suggested by people who've given evidence earlier today that people might start exploring the option of assisted dying for fear of feeling a burden, and that the law can't adequately deal with people who might be sort of self-pressurising themselves. I just wondered, in your experiences, is that something that you have seen and witnessed, and how do you address that motivation with your patients? Whoever, to both of you, really.
Sure. So, do people often feel that at the end of life? Just in general, I think that conscientious people will often think about their family and how their situation is affecting their family and loved ones. I think that that's something that many people go through, and so that is something that comes up relatively frequently. It's usually embedded within a laundry list of reasons that people are looking for assisted dying. It's more of, when people bring it up to me, it's more of a commentary on what they don't like about their dying process is that they are also feeling like a burden to their family. That is a red flag for me, though. If somebody said, when I ask them, why are you reaching for this, and say, well, I'm a burden to my family, that's a red flag for me as a physician. This goes back to the capacity, coercion, all that argument, because we're trained professionals who listen for these kinds of things. This isn't a rubber stamp evaluation. when we ask people why they're looking for this, we really want to assess their judgment and see what their reasoning is. If they're saying, I'm suffering intolerably, I've tried all of the things that palliative care is offering me, or just my regular physician is offering me, and I'm still suffering irrevocably, and also there's this other piece that I see what this is doing to my family, that's totally valid. That's something that any of my dying patients might say, whether or not they're seeking an assisted death. If it's their only reason, then yeah, that's going to lead me to ask a lot of probing questions and would be a red flag for me. But that is incredibly rare that something like that would be the only reason. Dying is a very complex process, and people's thought processes during their dying, during their own dying, are equally complex. So there's a lot of things that people think about during that time.
Thank you.
I will just jump in and echo what Dr. Spielvogel has said here. I think it's very, it is common that amongst the list of things that people mention as reasons, they may mention not wanting to be a burden on their families or not wanting to put their families through, an onerous and prolonged dying process. And I will say, obviously, yes, I think if that's the only thing that they're mentioning, that definitely will get them further discussion and further exploration into what's going on here, what are the resources that we can point them to, connecting them with social workers and available, community resources for helping with caregiving, etc. However, I think that I hear most commonly that this desire to save their families from this kind of really prolonged dying process really comes mostly from lived experience, where they themselves went through this process with a loved one of mother or father and were caregivers for sometimes years, and did feel that it was a burden on them, although they were happy to do so and it was loving, but they have that lived experience and they're looking to save their family from what their experience was. So I think it's common that people feel some element of that when they're in a situation where they're requiring heavy caregiving. And I think it also goes back to autonomy. I think people that are in their right mind and have capacity to make this decision should have the autonomy to have their reasons and their value systems respected, whether or not we share them or would see it in the exact same way.
Thank you.
Thank you very much. I'll keep mine quite short, but is there anything about the law in either of your jurisdictions where you think there could be improvement and where we can learn from when we're drafting our current legislation here? Both of them, sorry.
I will jump in to say the thing in your law that I have been reading about and is concerning to me is the court reproval that you seem to have written into the law, and I heard this morning earlier discussion about how that might be done and whether it's a committee or a high court, etc. But I think that's really going to limit access to this. I think that makes this process a much lengthier process. And again, these are people at the end of their life. People are not looking to cut off, by and large, a huge amount of their life. They're looking to shorten their death, not shorten their life. And having to go through a court appeal in addition to 2 qualified physicians having to do it and the waiting period, I think that you are going to limit access to people who desperately do want this option. And so it seems like that might be baked into your law, but I would say that would be a concerning feature to me, that I think that you're going to limit access that way.
Yeah, so something that it turned out wasn't in our law, but everyone thought was for a few years, that really limited our practice was many people were under the impression that the physician couldn't bring up assisted dying with the patients, that the patients had to bring it up themselves. And that turned out not actually to be in our law, but I'll tell you, that idea really, really hampered our ability to take care of patients. And so I would strongly recommend that there not be anything like that in your bill, because people can't make informed decisions for themselves if they don't know what their options are. And while this is top of mind for all of you, and it's top of mind for the doctors, So we all know that this exists. I'll tell you, the general population is still not going to realize, even if this becomes law, that this is an option. You know, I eat, sleep, and breathe this here, and when I have my own patients, because I'm a primary care physician, who have been newly diagnosed with a serious life-threatening illness, and I'm going through their options with them, I say, okay, here's what disease-directed treatment would look like. We continue with your chemo, we continue with that. Here's some side effects, complications you might have. Here's the benefits of that. Here's what palliative care, what hospice care would look like. And then I say, and then in our state, I don't know if you know this, but we have this other option for people nearing the end of their lives when they're having intolerable suffering, that you can ask me to fill a lethal prescription for you to help end your suffering sooner. The number of times that people look at me and say, oh, you can do that? That's an option here, is astounding. I'd say it's probably 9 out of 10 of my patients that I have conversations with who have no idea that this is even legal. So if they don't know it's an option, they're never going to ask for it. So for physicians to be able to do their jobs properly and deliver care to people, and for people to actually have a choice, physicians need to be able to discuss it with their patient. So that's what I'd say.
I'll just piggyback on that as well. Just say I cannot count the number of times that I have given a presentation to communities or given a talk, and people come up to me afterwards, usually family members of someone who has died not using this law, saying, you know, thank you so much for what you've said. We were interested, or my loved one was interested in having this information, or they wanted to talk to their doctor about it, but their doctor never brought it up, and so we weren't sure if we should be bringing it up. And it's a huge burden to put onto patients and their loved ones to have to bring this up themselves. And I would highly caution against any sort of language that requires that, because it's just not fair to them. They're already going through so much, and as Dr. Spielvogel has said, you cannot have an informed decision-making discussion with a patient if they do not have all the options available for discussion.
Mr. Stephen Kinnick.
Thank you very much. I just wanted to drill down a bit more into the question of training. Could you just say a bit more about how the training works? For example, is it mandatory for everybody that's taking a medical qualification to a certain standard? How many class hours are required? Is there a shadowing, in-practice shadowing process? Is there an assessment process to verify that the person is qualified as a result of the training? Questions like that, really, just trying to get a bit of a better sense of the detail on the training. Perhaps start with Dr. Khan.
This is a really important question and a really important topic in certainly here in the United States. Our laws all are very clear that participation is voluntary, and so therefore there is no such mandatory training across, medical training in general. It's always voluntary. If a physician or a provider wishes to have training, then they can seek it out. I think it differs from state to state what is available and what the standard of care is in that state. Certainly in the state of Washington, where I'm the medical director of the organization that kind of is most largely involved with this, that's really the bulk of my job, is doing these training, mentoring, shadowing, as you say. There is no exam at the end of that process, but certainly there is a shadowing and a feedback process involved with that. I will say I'm also heavily involved with the Academy of Aid in Dying Medicine, which has been very active in creating professional trainings. We have a Journal of Aid in Dying Medicine, which is a peer-reviewed journal that is putting out articles relevant to the topic. And the Academy of Aid in Dying Medicine is now undertaking certification pathways where each level of providers, so social workers, chaplains, physicians, anyone that might be involved in the aid in dying process, will be able to take these certifications, and it's a more uniform education system that will be available. Now, we're just at the beginning of creating those, but it's very exciting and we're very happy to have those out. So there are a lot of resources out there already in the world in general to train providers how to do this well. And I think it would be really smart to have something in your bill that does outline what the training should be, whether or not you're going to have it mandatory or voluntary, and perhaps some sort of certification pathway as well.
Thank you. That's fine. I don't know if Dr. Spielvogel had anything new to add to that, but if not, that's fine. Thank you very much.
Yeah, I was just going to add to that without repeating anything that Dr. Khan said. So I am, in addition to my assisted dying hat, I'm also program director for family medicine residency program. So my main job is actually training young physicians who are becoming what you would call GPs. And so we've instituted curricula as part of our residency program here to train interested physicians in learning how to do assisted dying. There is a whole process that we go through for that, including lectures, them shadowing, me then shadowing them and listening in on their conversations, giving them pointers, and kind of walking them through all the steps of the process. Where then they do this with multiple patients through the course of their residency, so when they graduate, they feel competent and confident to be able to offer this care. I do think that, as with most medical training, this should be included in that part of the training process. All the other things of pathways and continuing medical education is very important for physicians out there in practice who want to start doing this, but really getting this into medical training at its roots, I think, is vitally important for also normalizing the practice. Speaking of which, something else that I've heard a lot is that this might be distressing to physicians, or that physicians wouldn't want to offer this care. I would just like to say that 80% of our residents in our program opt to receive this training. And when we did a study on this of our graduates from our program who were continuing to offer assisted dying, 70% of the surveyed residents said that their assisted dying work was more rewarding to them than the rest of their primary care work. 70% said it was more rewarding. So I just wanted to also combat this notion that physicians would feel burdened, or that this would be some sort of psychological negative to physicians practicing this. It's actually quite rewarding work, and has led me to be a better physician to my patients, all of my patients, because it has helped me in how to have difficult conversations and these difficult end-of-life conversations with them. So that was a bit of a twofer. Sorry, I added that on there.
Thank you.
Thank you. Danny Kruger.
Thank you very much. I've got 4 really quick questions. I'd be very grateful if you could just try and answer really quickly, because we've got to let everybody else in before the end of the session. So I will be very, very fast. I was just struck, Dr. Spielvogel, by you saying that 9 out of 10 patients that you've suggested this option to weren't aware of it. I mean, how many people do you think that you might have suggested assisted dying to as an option who didn't know about it before have taken it up? How many people do you think benefited from you telling them about the option?
A lot. I've been actually quite surprised. So, and everybody's different, right? This is the whole point, is that different people have different goals, objectives, values. And so I've had people who I mention that to, and they say, oh, no, I would never do that. And I never bring it up to them.
But just, sorry, how many do you think?
And I'm definitely also...
Order. Don't interrupt the witness, please. Let him finish, and then you can come back with the question for something. But please do not interrupt the witness.
I apologize. You're quite right.
No problem. So to answer your question more directly, I've had several over the past couple of years who had no idea it was an option and said, that's what I want to do, and then went through the process with me. So
okay, thank you very much. I was also concerned by what you said about what you call family coercion, I think, which is people trying to stop their relatives taking this option. Is there anything you think we can do to prevent that happening?
Yeah, I think it could be made into a misdemeanor or felony or whatever the equivalent is over there. Sorry, I don't have the terminology. Make it illegal to interfere with a patient's right to make this choice. We stopped short of that in our most recent addendum to our law here, but I think that was an opportunity lost.
Okay.
Because yeah.
Okay, thank you. I'll just jump straight to my final question. I won't ask two. To Dr. Khan, I think you said that you felt that people who feel they might be a burden were exercising their autonomy, and it was perfectly appropriate, is an appropriate reason to seek an assisted death. Is that right? And do you think there should be we could do more to reduce or make it easier for people to access this right? Do you think they should be asserting anything other than their wish to do so?
I think you characterized it correctly in that I do think, people who have capacity and are making this decision to have this as an option, and part of their reasoning is that they want to save their family from an onerous caregiving experience. I think that is their right, and it is part of their value system. Now, of course, if that's the only reason, we're going to be exploring that, as Dr. Spielvogel has said, that's a red flag as well, and we're going to be exploring that and exploring whether there are acceptable alternatives exist and what are the resources that they may not be aware of. So that's always part of the discussion. These discussions are always broad and multifactorial. But I think it is appropriate and okay for somebody to say, I don't want to, have my family experience something that I had to experience, for example, when I was caregiving for my elderly parents with dementia. I've heard that many, many times. So I do think people who have capacity should have their autonomy respected in terms of what are the values that are driving them to make this decision. And in terms of what you can do to I think we always want to work towards improving the social supports for caregiving that exist in our society. I think there's a lack of it here in the US, certainly, and probably there in the UK as well. And so hand in hand with allowing people to make a informed decision about the option of having an assisted death, I think you should also be a strong advocate for social support and caregiving services at the end of life, because those really are important and needed.
Thank you.
Thank you. Nasha.
Thank you. This is Dr. Spielvogel. If you could just, there's a bill in California, SB 1196, and it was introduced in February 24. It proposes to, 1, remove the 6 months terminal illness prognosis and allow requests for those with a grievous and irremediable disease causing unbearable suffering. It also to allow dementia patients to request assisted suicide if 2 doctors deem they have capacity. 3, it allows self-administration of lethal drugs via IV infusion. And 4, eliminate the sunset clause in the current law. Do you know what the current status of that bill is? Is it still live? Because it suggests a significant broadening of the law, which would have similarities to Canada and quite a slippage, the slippery slope argument. It would suggest that reinforces it.
Yeah, it's a good question. So I don't know the specific status of the bill, but I would assume that it has itself undergone an assisted death at this point. That bill is not being supported by really any of our advocacy groups or the physicians by and large who perform assisted dying, because it is, like you mentioned, very broad and not aligned with how we feel like kind of standard practice is going and where we would want to see it go. So that bill did not receive support from any of us.
So just to follow on that, the conditions in California, specifically, we're talking about kidney failure, renal failure, and they've got a 6-month limit in some cases because of insurance policies. So is that being broadened out? Is that being, because I understand there's a huge difference between American politics and how the laws from lobby groups, etc., and what influence those insurance companies have, because we have an NHS which those restrictions don't apply to. So have you done any analysis on that, or how would you respond to that?
Can you clarify what you mean about the kidney disease and 6-month prognosis and the interplay with insurance there?
So in particular, when it comes to renal failure, there are people who can then request assisted dying because their insurance company won't pay for more than 6 months. Now here we have an NHS which there's no limit on the kind of interventions you'd have to live a longer life.
So that is not factually accurate. When people go on dialysis, they automatically get Medicare, which is our version of NHS, more or less. And so that's a national health insurance for people who are 65 and older or who have certain kinds of disease states. So when you have end-stage kidney disease and you need dialysis, you automatically get Medicare, and you get dialysis for the rest of your life, however long that is. People are often on dialysis for years, so there's not like so you're on it for 6 months and then you're on.
Does that cover all conditions?
Well, we were just talking about kidney disease.
Yes, but does it cover any conditions that would fall under the scope of a 6-month bill that you've got?
So if you have a 6-month prognosis to live, regardless of the condition, that would fall under this. That would make you eligible. That has nothing to do with insurance coverage for your condition. Insurance coverage is completely separate. It's not tied to this. All that your prognosis does is it allows the individual to seek this care.
So sorry, the question, just for me to clarify, the question was, would Medicare, the availability of Medicare, apply to all those conditions that come under the 6-month prognosis to meet that criteria? Like kidney failure, they'd be entitled to Medicare. Would all the other conditions included also be entitled to Medicare once their insurance ran out?
No, this isn't about, insurance doesn't run out. So I think that there's maybe a misunderstanding of how medical insurance works in the US. Medical insurance doesn't run out. So I think we're talking about two different things.
But when they stop paying for it, there are cases where insurance companies would stop paying for the treatment of the individual. Am I right?
No, I actually don't think that you're right. When we're talking about things like cancer and chemotherapy or dialysis, life-saving interventions, that's not correct. So they are bound by law to cover all things that are medically necessary. And so they don't just say, you've gotten 6 months of chemo, we're not paying for any more. That's actually not how it works.
Thank you.
Okay, thank you. Sean Woodcock.
Thank you. It seems very clear from what you're saying that coercion is rare in your view, or at least in comparison to coercion from family, or let's call it familial pressure not to go ahead with assisted dying, that it's rare in comparison. Although it does sound like you're saying that the feeling of people saying that they're feeling the burden towards the end is more common. I think it was Dr. Khan who said it was common, or certainly less rare than the coercion to assisted dying. We heard from experts earlier about the paucity and the lack of provision of care across the country, so that certain people can get access to very good care, but too many people struggle to get it, particularly people who are of certain ethnic backgrounds, people on low incomes, etc., etc. It sounds though, from what you've said so far, and please do correct me if I've misinterpreted your views, that exercising your right to assisted dying because of a paucity of appropriate care in your locality, or you can't afford it, whatever, is a perfectly legitimate exercise of your autonomy based on society around you. Would that be a fair assumption of your views?
I think that's directed at me. I think that's not entirely fair of what I'm saying. I think that, yes, we do need to respect for people's autonomy for the reasons that they may come to this choice. But I also think that from what I've heard this morning, it sounds like there's a conception that it's really like people choose assisted dying and then they do it. And what I see by and large is that people want to have this as an option. It's an option amongst the other options of hospice, palliative care, sometimes, palliative treatments. And the availability of this as an option often brings people tremendous relief from their suffering, just from the anxiety of how they might die, of what suffering might be in store. Just briefly, I had a case of a woman with ALS, amyotrophic lateral sclerosis, who was very afraid of how she might die with that condition and feels like she might suffocate to death. And she was so focused on having the option of aid and dying because she was terrified of what might be in store for her. And we were able to incorporate her into a hospice that offered comprehensive end-of-life care, including the option of aid and dying. We got her through the process, we had the medications available, and she told me how much relief she felt from having this as an option. And ultimately, she decided not to use it. She decided that she was getting really good care from her palliative care and hospice teams, that her symptoms were well controlled. And although she was extremely grateful that she knew the medications were available should she decide to use them, she did not end up needing to use them or wanting to use them. And so I think that's really the realistic thing of what's happening in a lot of cases, where this is an option amongst other options, and the availability of this option is in and of itself a palliative care treatment for many people. So whether or not I think, the wanting to avoid being quote unquote a burden to a family member or to a caregiving team is a valid reason to pursue this, yes, I think that is a valid reason amongst many for people who have a value system that highly orders that.
Thank you.
I just wanted to add, if I may, I've heard this argument, or rather this concern, a few different times, and it strikes me as what's called the false dilemma, logical fallacy, that there's either or, when in reality there's many alternatives that people can choose from. So, saying that if we don't have all of these types of care, we shouldn't offer this option, is like if you have a hospital that doesn't have sufficient amounts of IV pain medications, saying to a laboring woman, well, we don't have enough IV pain medication, so we're not going to offer you a labor epidural because that's a false choice, right? That doesn't actually make sense. If you look at it from the patient's perspective, think about a patient who's dying from terminal cancer and in lots and lots of pain and doesn't have any good options for their pain control. To say to that person, we don't have all of this care, this option over here available to you, so we're not going to allow you to have an assisted dying, even if they're telling you, this is what I want, why won't you give this to me? So it doesn't make sense to remove this as an option just because all of the options might not be available to everyone all of the time. It's a bit cruel when you think about it from the patient's perspective.
Thank you. Now we have 2 minutes left before the evidence session finishes. Dr. Simon Offer, I'll ask you to make a very quick question and perhaps a short response. I don't want to interrupt our witnesses at the end.
Yeah, can I just ask you very briefly, what happened? What was the feeling before this came in the general population and with doctors, and what has since happened since the law has been in place? Because it's been in place since 2016, I understand. So just a very brief description of, were there anxieties before, or were most of the public in support of it?
So really briefly, I literally had not formed any kind of opinion on this. So when I was in medical school, it wasn't talked about, we didn't talk about it, we didn't discuss it. It just literally wasn't a thing. And then when it became law in California, I still hadn't really thought of it until my medical institution asked me if I wanted to participate. And I said, sure, I'll give it a try. And then with my first patient, I saw how amazingly transformative it was for him, for his family. When I had seen lots of death before then and saw how tragic and just traumatic it often was, and how this was a dramatically different experience, and I became a convert. Since then, I've seen many other physicians undergo the same journey with their patients, being very ambivalent to it until they have a patient who's asking for it. They go through it with that patient who they've known for a long time, and then they come out on the other end realizing just how amazing this option is to the people who want it. And again, I'm emphasizing this is a choice. For people who don't want this, they don't need to have it. For doctors who don't want to do it, they don't have to do it. But for the patients who want this, it is incredibly powerful piece of agency. And I'll leave it to Dr. Khan.
Yeah, so I have, the jurisdictions I work in have quite a bit more experience. In Oregon, of course, it's been legal since 1997, and in Washington State since 2008. Both of those laws were actually started by voter referendum. So the general populace at large wanted this, and that's how these laws got started in both of these states. And so the general population has by and large been supportive, and each year growing more and more supportive of this as an option as it becomes normalized, as it becomes clear that this is a practice that is careful and safe and has appropriate safeguards in place. And I will say that the medical community has also come along with that. So in the state of Washington, again, we have now 15 years of practice with assisted dying. And when this law was first passed, there was hesitancy in the medical community. This was an unknown in many regards. We were the second state in the entire United States to pass this law. And so the medical community was a bit hesitant. And I will say in those last 15 years, we've seen a tremendous growth in the support of physicians and the medical community at large in wanting to make sure that this is an option for people, that people do have access. Just my own experience here in the state of Washington.
I'm sorry, Dr. Khan. We've come to the end of the session. I do apologise. I hope it doesn't sound rude, but we've come right to the end of the session. So thank you for your contributions. I'd like to thank the witnesses, Dr. Spielvogel and Dr. Khan, for your time. It's our procedures in Parliament, regrettably, that require me to do that. So thank you very much. It was very valuable. In that case, the time allotted for the committee to ask questions is gone. So thank you very much to our witnesses, and thank you for all the contributions and your forbearance in this very sensitive subject. Thank you very much. Point of order, Danny Kruger.
Taking notes of this, I just wondered whether, given the fact that we've had so many really helpful conversations and questions, but we didn't have enough time for everybody to ask everything they wanted to, whether it would be appropriate for members who want to write to witnesses to ask for follow-up information or further questions could do so through the committee, rather than us all deluging witnesses with our own letters, some of which will duplicate each other. I appreciate that there's a capacity question for the clerks, but it might be appropriate to ask the Speaker for a bit more resource to enable that to happen. And I think that Ms Ledbetter broadly supports the idea. I don't know if others do as well.
Okay, well, on that point of order, I mean, witnesses, let's be clear, witnesses can submit written evidence until the committee reports to the House. And it is open to members to individually write to witnesses, to invite them to give written evidence if they so wish. And my advice to the member was, if he wishes to look at this in a more formal way, or a more formal mechanism, is to speak to the committee clerks about that, because that's beyond my remit, I'm afraid. So thank you very much for that. We now come to motions A to D, amending the sittings motion tabled by the member in charge. An amendment has been tabled to motion A. I've selected the amendment. I will group all four motions on the amendment for debate. I will first call Kim Leadbetter to move motion A, and then Naz Shah to move the amendment. The scope of the debate is all four motions on the amendment. I call Kim Leadbetter to move motion A.
I'd like to move to motion A, Chair. Thank you. These amendments enable additional witnesses to be called to give oral evidence, including a representative from Disability Rights UK, the Royal College of General Practitioners and the Royal College of Psychiatrists, and an expert in Welsh devolution and constitutional matters. I think, as the sessions today have shown, hearing from expert witnesses is an extremely important part of this process. So I hope I have the support of the committee in making these additions. In terms of the call to add, the motion to call additional witnesses from my right honourable friend, the member for Bradford West, I respect the suggestion, but I'm confident, actually, Chair, that we have an eminently qualified witness to cover issues around coercion and domestic abuse in Professor Jane Monckton-Smith, who was suggested by my honourable friend, the member for Bradford West. And we've also heard today, and will hear from many witnesses over the next few days, medical, doctors, nurses, social workers, palliative care experts, geriatricians, around 50 witnesses in total. So whilst I fully appreciate there are a wide range of additional charities and organisations who have valuable contributions to make, I would encourage them to submit written evidence so that the committee has the benefit of those thoughts. And Chair, in terms of the start of line-by-line scrutiny of the bill, given the huge volume of both oral and written evidence we have and are receiving, I've consulted with colleagues across the committee, and there is a consensus that having next week to absorb and evaluate the evidence and prepare any amendments in light of this is extremely important. And as such, we would begin line-by-line scrutiny on Tuesday the 11th of February as per the motion. Mr Dowd, I hope these amendments demonstrate the robust approach that myself and the committee are taking to our work and would encourage colleagues to support these motions. Thank you.
Okay, thank you. Thank you very much for that one. The question is that motion A on the amendment paper be agreed to. I call on that show.
Thank you, Chair. And I completely agree with the member that, and I'm grateful for her adding on Monckton Smith onto the witness list. And I absolutely agree that this evidence is really, very valuable. However, what I would say, and this is an amendment that was tabled by the Mother of the House yesterday, which I've added my name to after the Royal College of Psychiatrists include Richard Robinson, CEO of Hourglass, Cherry Henry Leach of Stader, standing together against domestic abuse. And the reasons are, Hourglass focuses on domestic abuse of older people and is particularly noted for the majority of victims are female. They estimate 1 in 6 elderly people believed to have been victims of coercion in the UK. This raises serious concerns that they could be pushed into ending their lives if the bill is voted into law. They have not published a public opinion on the bill. STADA have said we must echo concerns raised by violence against women and girls sector and disability activists about the bill's current safeguards. There is insufficient clarity on what constitutes coercion and limited reflection on carer capacity to support somebody terminally ill. Without robust measures, there is a real risk that assisted dying could be exploited as a tool for coercion or even femicide. Statistics show that over 88% of unlawful mercy killings are perpetrated by men towards women, often involving violent means. These troubling realities demand urgent consideration in shaping this legislation. We also highlight the health sector's role in identifying domestic abuse, with 80% of victim survivors having their first or only point of contact in healthcare. It is critical that health professionals are equipped to identify and respond to abuse. We call on the government to ensure the proposed bill includes stringent safeguards and that the healthcare systems are equipped to recognise and prevent the potential misuse of assisted dying. Femicide is already a crisis in the UK and no law should inadvertently contribute to its escalation. What I would also add, Chair, is that I have more than, well, all my adult life of experience dealing with domestic abuse and coercion. I speak from that experience to these amendments. And while Professor Jane Monckton Smith is an actual expert, she is an academic, and these two organisations work with people who are facing abuse, who have been victims of abuse. In addition to that, when we discussed the original, when we had a meeting, which was not an official meeting, it was an official meeting with the clerk to have an introduction to the sitting proposals. It was said during that meeting we would only be having people who would attend to give evidence, in particular in person, which would contribute to the deliverability and the workability of the bill. Since then, we have had families added to the bill. So from that adds weight to the argument that actually perhaps we should have people who are actually dealing with and providing a service to victims directly. And I beg to move this amendment.
Thank you. The question is that the amendment be made. Yeah. Marie Tyndall?
Yeah, thank you. Just to say that I support my honourable friend from the Spen Valley, and in particular want to highlight the helpful addition of Cameron Malik from Disability Rights UK. This augments already comprehensive list of expert disabled people, which includes Professor Tom Shakespeare, who is an internationally renowned disability rights academic, Dr. Miro Griffiths, who is a disability studies scholar at the University of Leeds, as well as Chelsea Roth, who is founder of Eat, Breathe, Thrive. We also have on that panel the EHRC, who will be able to give a good overview on the intersection between protected characteristics, and then finally the representative from MENCAP, John Sparks. And I'm really pleased that the member has worked so hard to ensure that the voices of disabled people are integrated across a number of the panels that we will see over the next 2 days. And I think the addition that in her amendment this afternoon is really helpful, and commend her for that.
Okay. Thank you. Kit Malthouse.
I also want to support the members of Spen Valley's amendment, in particular the addition of Jane Monckton Smith, whose book I have read. If you haven't read it, then it's definitely worth a read, and it's pretty alarming. And in particular, just to address the, why I don't think the committee should support the amendment put down to add other committees. Jane Monckton Smith has done a huge amount of research in this area, and not as well as being an academic who specialises in coercion and indeed in femicide and the impact that coercion can have on femicide. She's a former police officer and so has quite significant frontline experience as well, and as part of her research will have spoken with and interacted with many of the groups that are that the member is proposing to put on the, although maybe not specifically, but is proposing to put on the order paper. So I would prefer if we stick with the list that the member for Spen Valley has put on, and not necessarily add the additional witnesses proposed.
Do you want to speak? Lewis Atkinson.
Thank you, Chair. Just very briefly, I think I agree with my honourable friend, the member for Spen Valley. I think also having agreed to extend the time on Thursday and the proposal to hear on devolution issues from the Royal College of GP and the Royal College of Psychiatrists, the amendment by adding 2 further witnesses would reduce the time available on those options. So, clearly in an ideal world we would like to hear from all sorts of people. The options of written evidence is available, and we have got other evidence, and I want to make sure that we're focused in that session on Thursday on the proposals that the member for Spen Valley has made.
Thank you. Shah.
Can I just respond? Whilst there is nothing in this amendment which I've supported which suggests that Professor isn't capable in what her expertise is, what I am asking is for another expertise to be brought to the table. And whilst, yes, there is the argument of people can submit written evidence, as could have every single witness that we've heard from today, that we will be hearing from tomorrow, and indeed the day after. If that's the measuring yardstick, then is this just a tokenistic exercise? I would argue for women in particular who are the victims of domestic abuse, we are not hearing. Sorry, yes,
just to note that Laura Hayano, who is listed to give evidence on Thursday, is a domestic abuse barrister. She's also been involved in inquiries on child sexual abuse and has a great range of experience in that area. So we'll also bring that as a practicing barrister working close on those kinds of cases to the table.
So if I can, and I welcome the Honourable Member's intervention, and I absolutely recognise her expertise. What the pushback from me would slightly simply be this, respectfully, that as a victim of domestic violence, as a person who's experienced it, who's campaigned on it for all my adult life, the difference between an academic who studied it and people who have worked with victims, and in particular I'm referring to elderly people here, and elderly women in particular. This expert you referred to is a barrister with young people, with children and domestic abuse. That's what you've just said, unless you want to expand that. And Professor Monckton Smith is also an academic, and yes, has been a police officer, but working with victims of domestic abuse in particular, I would value that. That's all I have to say on it. Thank you.
Thank you. The question is that the amendment made by Naz Shah be made. As many of that opinion say aye.
Aye.
To the contrary, no?
No.
I think the noes have it. The noes have it. The question is that the motion A on the amendment paper moved by Kim Leadbetter be agreed to. As many as that opinion say aye. Aye. Contrary, no. I think the ayes have it. The ayes have it. Kim Leadbetter to move motion B formally. The question is that motion B on the amendment paper be agreed to. As many as that opinion say aye. Aye. Contrary, no. I think the ayes have it. The ayes have it. Kim Leadbetter to move motion C formally. The question is that motion C on the amendment paper be agreed to. As many as of that opinion say aye. Aye. Contrary, no. I think the ayes have it. The ayes have it.
Mr. Chair.
Yes.
I'd like to move that the consideration of the bill be now adjourned.
No, we haven't dealt with
I thought you were looking at it.
No. Just bear with me. Bear with me. Chair, sorry. Kim Leadbetter to move motion D formally.
Motion D formally.
Good. I'm pleased you did that. The question is that motion D on the amendment paper be agreed to. As many of that opinion say aye.
Aye.
Contrary, no. I think the ayes have it. The ayes have it.
Mr. Dow, once again. I beg to move that further consideration of the bill be now adjourned.
Okay. Those in favour of, those who agree with the adjournment, say aye. Aye. Contrary, no. The ayes have it. The ayes have it. Thank you very much.